I don't join. Don't join meeting. The time vanish. The meeting will be say I want download Zoom for join. Sickle cell, blah 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 blah.
Are you sickle cell anemia?
Eh?
That's sickle cell.
No. So my uncle Mano, Palava, healthy. New uncle was recently knowing he is a medicine. Any healthy. It is send. It don't send and tell us try job. child you know be don
Hello.
Hello. Hello.
Yeah, so we are live. Just to make sure that we have already 11 participants. So do we have the technical team? Are you sure that the moderation rights are offered to the various key people? Hello. It looks like Mr. Folabi is not on.
He's on, but he's on mute.
Because we just want to make sure that all the speakers are actually on the moderation. Otherwise, how is it going to? Well,
He can hear you now. It's unmuted now.
yeah. Mr. Folabi, can you hear me? Oh dear. Hello.
There's pop-up, so people can yes, there's pop-up.
Are we there now? We are in.
We are with them.
Can hear you.
Yes, you can hear. Good.
I can hear you.
Okay. So can you just make sure that, because you are doing the technical job and you've been fantastic, I just want to hope that all the people who are speaking actually have moderation. I mean, you have all the flexibility that will require of them, right? Or will you be the one changing the presentation?
Yes. You can pick pop-up. You are welcome to go and start pop-up, Nigerian pop-up and Cameroon pop-up.
We have all the flexibility.
Okay.
Yes.
Is Dr. Yinka, is Dr. Oduwaiye, is he listening to us? Hello? Dr. Oduwaiye, are you listening to us?
I just realized I can't share my screen, so I don't think I have.
Yeah. Did you hear that?
Yes.
I can hear.
Dr. Anambene just said she can't share her screen. So presumably, have you got her updated PowerPoints? I sent them through to Dr. Oduwaiye a moment ago.
Yeah, I'm hearing you.
I sent it to
Yes, I did. I sent it to Afolabi. You want me to resend it?
No,
No, I think he has it. He has my PowerPoint because I sent it to him.
Okay.
But
So
I think if you promote the speakers to like co-host, then we can be able to share our screen.
Okay, you can share your screen now.
All right.
Yes,
I can now.
So everybody in the room can have pop-up at least, and then we start going. We hand over to our chairman in Edinburgh, and then he can. So, all in the room, you are all welcome to the SAOF summer seminar, and it's on sickle cell Anemia. The SAOF in the UK, Nigeria, and America, we partnership with other organizations, not only to talk about cancer, but to talk about chronic illnesses. That's why we organized this Sickle Cell Anemia webinar for this summer in the UK. And all our friends and partners all over the world will be joining in exactly this time. So we'll hand over.
Hello, we're just doing some sort of a technical test. Mr. Van Lare, can you hear us? You are muted. Can you just say yes so that we can make sure that we can receive you? You're not talking. You need to unmute yourself.
Hello, doctor.
Mr. Van Lare, can you hear us?
1 second. I am unmuted now.
Yes,
I can hear you.
us?
I hear you well.
Yes,
please.
We just want to
everybody is just talking at the same time. I don't know whether it's.
No, okay. Mr. Afolabi, Dr. Oduwaiye had passed the microphone to me. So what I'm doing now, I'm just wanting to make sure that we can hear all the key speakers across the globe. So that's why I started by asking Mr. Van Lare if he could hear us, and he's responded. So, and we can also hear him. So can we find out, Dr. Anambene, can you hear us?
Yes, I can hear you.
Okay, and we can see you very well on the full screen. So that one is ticked off. Let's find out if Dr. Kamara and Dr. Obale, are they on? Dr. Obale, are you on?
Unmuted. Hello?
Oh, okay, yeah, wonderful. So it's great to see you. We just want to make sure that Dr. Kamara is also on. Is he going to join us by Zoom, or how is he linking us with?
Yeah,
he doesn't seem to be online. We can't get him online. We cannot get him online.
Yeah.
He's not on. He's not joining yet. But we just want to make sure that all the key speakers are actually on. No, we can't. We can't get him just yet. I'll assume that by the time we get to his slot, he would have come on. Can I just find out all the patient groups? The patient groups. I know that Mrs. Ansah and family are actually in the. Okay. Just before I come to Laura, Mr. Ansah, can you hear us? Are you? Or you're actually in the conference room, right?
Yes, I am.
Wonderful, and you and your wonderful children. I can see them from here. Can we just confirm that Miss Damilola, is she on?
Yes, sir, I'm on, sir. Good afternoon,
Wonderful.
everyone.
You can
Yes,
actually,
sir.
but we cannot see you.
Oh, sorry.
You
Let
need
me,
to put your video on.
Okay, sir. I think the host has muted my video. I think I can.
Mr. Folabi, is there anything we can do so that, because it's important that when Ms. Damilola is speaking, that it's important that we're able to see her. I keep saying Ms. Damilola, it's actually Ms. Damilola Ajibode. Is it Ajibade or Ajibode? Pardon my.
Ajibade.
Ajibade, okay.
Yes, sir.
My Eastern Nigerian accent is not working that
Yes,
well.
sir. No problem, sir.
Okay, dear. Can we find out if okay, we have Laura on. Laura, Laura is one of the groups from Ireland. Laura, can you hear me? We can.
Yes,
okay.
I can hear you. Thank you.
Excellent. And we can I just suggest that when you're talking, Laura, you need to adjust your camera so that a little bit lower so that you'll be sitting up. Because
Okay.
at the moment we're just seeing your face. Is there any way you can do that? Is there any way
Yes,
you can where you are?
I will sort it out. Thank you.
Okay, okay.
Thank you.
That's fine. From the UK, Marie Claire, are you on? Plasma of Hope. Marie Claire, are you on? Marie Claire is not on yet. Uganda, Sibandeki, are you on? Sibandeki, are you on from Uganda? No, it's not on yet. I suppose they'll join. We're joining later. Let's go to Cameroon. Mr. Ashuegwe, are you on?
Yes, I'm on.
Excellent.
Good day to everyone.
We have a problem with the connection. It's training, but we can see your beautiful picture. Thank you so much for joining. This is wonderful. So we can hear you, which means we can see you. So now you can go on mute so that we don't overburden the line. We just wanted to make sure that everyone is actually on the link. Can I find out if who else is it that we haven't got? It's only Dr. Kamara so far that we cannot confirm. Now, Esther from Ireland. I know Esther is a bit poorly, but this is the thing with our warriors, in the sense that in a situation like this, they will rise up, the triumph of determination, as we say in this field of endeavor. Esther, can you hear us from Dublin? Esther is not on yet, because I just want to point out that there are two user groups have actually offered to join into this initiative. So we have Esther from the Sickle Cell Society of Ireland, and we have Laura, who is also another lead Sickle Cell and Thalassemia of Ireland. Oh dear, there's a bit of noise coming through there. Okay, it seems like Mr. Afolabi, are you okay for us to go to get on?
Yeah, we are good to go, sir.
Okay. Okay. Good afternoon, everyone. At the moment, we have about 24, 25 people linking in, but of course, 25 link doesn't mean 25. Some people are gathered with families around and other groups. And of course, there's quite a number of people based at the conference center in London. So I hope people are hearing me. Anyway, so my name is... Thank you so much. Yeah, recording in progress, I've got it. So welcome to this global webinar on sickle cell anemia. It is essentially an initiative of the Sarah Ayoka Oduwaiye Foundation, who their main focus is actually on cancer, but of course they struggle for social justice. Sometimes it's called for partnerships, and this is why the Sickle Cell Anemia Initiative Advocacy Worldwide has decided to link up with the offer that came from the Sarah Ayoka Foundation to actually deal with it. So this afternoon, I should start by saying that, hello, Mr. Afolabi, are you?
Go ahead, sir. It's,
you're restricting the channel.
Yes,
So,
yes, very well.
My name is, for those, as I was saying earlier, Chief Asa'ah. I'm a clinical scientist, and I'm also a public health consultant based in the UK. A number of you would have come across me over the years because I've been involved with the sickle cell surrogate advocacy for over close to 30 years now. But my current remit is in reducing hospitalization in the UK. That's my current remit. Having said that, sickle cell is one. Hello? There seems to be so much noise in me. Some people might need to be muted, Mr. Folabi, so that we have just this person speaking should be the one leading me here.
Okay, sir.
So I was saying that my current focus is on reducing hospitalization in the UK. That said, sickle issues, sickle is one of those areas of surrogate advocacy that once you get involved with, as we'll see in this webinar, you get taken by it for the rest of your life. It is a very important aspect to show that we, as people of Black and minority ethnic communities across the globe, we have a medical challenge, a matter of social justice, which is what sickle cell is. But it's also, to an extent, it's nature's way. Nature has offered us, the BME community, an opportunity to show that we too can take a course to world-class level. And that's why it is important that we celebrate those groups that are going to speak today, the doctors who are going to speak, the families who are going to speak, because you're onto something really serious. We want to prove that we can also do advocacy to work like surrogate advocacy. So this afternoon, we're going to do we're going to talk from 3 dimensions. We will start with the medical side, which is part 1. Part 2, we will then get now to the people who are actually the movers and shakers in terms of addressing the challenge that sickle poses to people at personal level, at community level, at national level, and at global level. That's part 2. Then we will now come to part 3, where we now say, okay, we have a response for all these things that we've been hearing. The response will be, how can we formulate a position statement? That position statement will obviously give us the lever, the advantage, which we can use as an advantage to actually instigate real change after this, because I'm sure those of us involved in this social justice crusade, we always say after all, not another seminar. After this seminar, what next? This one is no one way after we're going to say what next. We're not going to sleep after this. We're going to make sure that we take what comes out of this to the next level. Personally, that's what I get committed. Otherwise, I don't get involved in this thing. So I want to reassure all the stakeholders who are actually here this afternoon, the next 3 hours is not going to be in vain. We're going to, and thankfully, we have the energy of the Ayoka Oduwaiye Foundation, really keen to make sure that we can take it to the next level. So the order, as I said, the 3 halves, the first half, the medical, then we now come to essentially the advocates. Then we go to what we call the response to those advocates. We now have the question and answer panel. And then we begin to finish now with some outline resolutions. So to kick off, we're going to start with a colleague, Dr. Anaemia. Dr. Anaemia is a specialty doctor in chemical pathology at Pinderfields Hospital in the United Kingdom in Yorkshire. And Anna is also my colleague on what we call Cameroonian doctors in the UK. I am not a physician. Anna is a physician. She's going to talk the real medicine. I'm a clinical scientist. I'm a pathologist, but not a physician as in the name of Anna. But we organize it so Anna will give us the basics and where we are with regards to treatment in this area before we move on to the next speaker. So Dr. Anaemia, you have the microphone.
Hi, everyone. Just permit me to share my screen. Or are you sharing for me? Okay, that's fine. Thank you for joining this webinar. As Dr. Asa has said, I am Dr. Anaemia and I work in the UK at Pinderfields Hospital. I'm just going to give you a brief basics of sickle cell disease, and I'll make it as simple as possible so that all of us can understand it. So next slide. So sickle cell disease is the most important hemoglobinopathy. That just means pathologies that affect the hemoglobin, which is a protein in our blood. And the WHO has put it in terms of frequency and social impact. So it is estimated that over 200,000 children with sickle cell disease are born every year in Africa alone. So this disease manifests with vaso-occlusive events. This just means that it blocks, you know,
yes,
the red blood cells.
So yeah, so yeah, so that's what she was just saying, that, you know, and that obviously I'm now going to be anxious because even though people are telling me that, okay, it's okay, there's not a problem, you know, and that things will.
Can you mute Dr. Bello? Okay. So the disease manifests with vaso-occlusive events. This just, it summarizes what happens. So the main problem with sickle cell disease is that this sick hemoglobin forms, these sick cells, they form lumps that occlude. So they block our vessels. That is why they call it vaso-occlusive events. So blocking the vessels are formed everywhere. They carry blood. So they go to every organ, and that is where we have the complications. So they have, we have episodic ischemic necrosis called crisis. So our crisis is just due to the fact that the lumps of these cells block the blood flow. Do you want me to share my screen myself? Maybe that'll be better. Share. I'll share this myself. Yep. Okay, that's better. So I have control of it. So, so this crisis that we normally have cause severe organ damage affecting the brain, skeleton, our lungs, that's the respiratory system, the vascular system, the spleen, and the liver. And this increases morbidity and mortality. So the rate of death are due to this crisis and its complication. So it is highly prevalent in Africa and India. And there is actually a reason for this. There's kind of a natural selection. So it is found that the sickle cell disease is actually endemic. So it's more in areas where we have malaria. This is simply because it impairs. So it actually kind of stops the reproduction of our malaria mosquitoes. So the Plasmodium falciparum, Plasmodium vivax, the malaria, and the Plasmodium ovale. And the heterozygous forms, which just means that just the carriers, they seem to be malaria resistant. So they are less prone to get malaria. So this mechanism, they call it kind of balanced polymorphism. So they have some kind of something bad, but the nature has made it in such a way, for example, those with sickle cell, they might die from their crisis, right? But they protect themselves from malaria, which is very, very dangerous in this area, in the sense that especially in kids. So although we might see the sickle cell, especially the homozygous, so the complete sickle cell carrier, the complete sickle cell patient, to have a disadvantage, instead, nature makes it in such a way that in that malaria area, you have the advantage of not having complications of malaria, like the cerebral malaria. So especially during childhood, where in these areas, children have a high mortality rate. So that is how nature has selected many people in these areas. So that's why we find them more prevalent in these areas. Nonetheless, they still find them in other European areas, like in the Northern Europe, because most often because of migration also, people move there, and due to movement, migration, will have a rise in prevalence in this area. For example, like in Italy, if you go to the Sardinia sites, which is an island, you will get people with sickle cell, and that is mainly because in this area, you also find malaria there. So in a nutshell, what is a sickle cell disease? It's just a defective red blood cell. So a red blood cell that doesn't work very well. So they say this is an autosomal recessive single gene defect. So this just means of our hemoglobin, which has got 2 chains. So we have the alpha and the beta chain. So what happens is that it is the beta chain that is actually sick. So when they say autosomal recessive, it simply means that for you to manifest the disease, you need to have to have both genes carrying the disease. So that's why we have the carriers and we have the sickle cell patients. So when I say chains, practically, as I said, it's just look at this picture. The hemoglobin that produces blood in our system is made up of 4 chains. So you have 2 similar chains that we call the alpha chain, and they have 2 similar chains that we call the beta chain. And these 4 chains now are kind of wrapped around a protein that contains iron and other proteins. And this, they carry oxygen in the body, all over the body. So, so it is actually the beta chain that has a problem, simply because what happens is our system actually is programmed to produce our proteins, right? So we have sequences. So what happens during this sequence is that in a sickle cell patient, what we call amino acids, which are our building blocks of our proteins, they have codes. So we have what we call codons that code for certain amino acids. So what happens is that one of these molecules is actually substituted. So we have is substituted, and it makes it gives a wrong information. So instead of producing an amino acid, which we call glutamic acid, it produces a mutant, which is a valine. So this amino acid now changes properties and it becomes what we call hydrophobic. Meanwhile, the glutamic is hydrophilic. It becomes hydrophobic, and what happens is that with the other proteins around it, it forms this conglomerates that it comes together. They come together and form other red blood. They come together with other red blood cells and other proteins around it, and they crystallize. So they form these balls. So what happens is that when this amino acid is changed and it gives the wrong information, it changes the form of the red blood cell and it changes the shape also. So it makes it to be harder. So as you can see here, our normal red blood cell is kind of a flexible disc that flows through the vessels. So the vessels are like pipes that carry blood all around our body. So you can see the normal red blood cell. What happens is that when this mutation happens now, they become the sickle cell shaped red blood cells instead. And the main property is that they easily stick to these vessels, so they don't flow easily. And you can see how they are forming all these blocks. And there are these blocks that go around. So when they form these blocks now, they stop the flow of blood, or they reduce the flow of blood to the organs where they are found, which means that those organs are having less oxygen. And when we get the less oxygen now, they will cause the death of cell. That is what they call ischemia around it. So, and this causes all the crises in different parts of the body. So as you can see, this diagram summarizes it. So what happens to the normal red blood cell is a disc shape. It's soft like a bag of jelly. It easily flows through small blood vessels. And most importantly, it lives for 120 days. What happened to the sickle cell? You have this sickle cell shaped and it's hard like a piece of wood. And it often gets stuck in small blood vessels. And it lives for less than 20 days. So you see that you have an increased destruction of this red blood cell. So as I was saying, it is a recessive, autosomal recessive disease. So what happens is that you can see this diagram just illustrates simply, if you have a normal individual, so AA is somebody who is normal, and then somebody who is a carrier. That is why they call it traits. So you just have the traits and you don't manifest the disease. You can see that if you get married to somebody who is, if a woman who is a carrier gets married to somebody who is normal, you have 50% chances of having a sickle cell, 50% chances of having a carrier, and 50% of having a normal baby. So if you have someone who is normal and has a trait, you can see that you have a 50% of having a normal baby and 50% still of having somebody with a trait. So if you have two people who have a trait, that is why it's very important that if you have a sickle cell trait, you should always get tested, or you should get your partner tested if you are thinking of having babies, because you can see that you have 50% of chances of having a child with a trait, and you have a 25% of having a child with a sickle cell, and then you have just 25% of having a normal child. And if somebody is actually sickle cell, if the woman is sickle cell and the man has a trait, you've got 50% of having a child with sickle cell. That's quite high. And you've got 50% of having a child with a trait. So it's very, very important. And that is why in the UK, they do the newborn screening. It's part of the newborn screening panel. They screen out for sickle cell disease, and also they can actually screen before the child is born. So what happens, the sickle cell complications, you have, it manifests in every organ, because as I told you, these blood vessels, which are like pipes that run throughout the body, they oxygenate everywhere in the body, from the brain right to the feet. So, what happens is the complications, first of all, are the psychological problems, so the mental health aspect of sickle cell. And then the central problem, because of anemia that carries oxygen, you feel fatigue, dizziness, fainting. Some people have low blood pressure. In the heart, you can have palpitation, rapid heart rate. And then for the crisis, actually, you've got chest pain. We have what we call angina. And for the skin, you can be very pale, coldness. You can have jaundice, that is the yellowing of the skin. This happens when these red blood cells that don't live for long go to the liver and they are destroyed. It produces a substance that we call bilirubin that gives you that yellowish color in the body. And obviously, because you're anemic, you don't have enough oxygen, you're easily short of breath. As you're breathing, you struggle with your breathing, and then it will easily cause muscular weakness because of less blood flow. And then you can have change in color in your stool. And so these are actually the signs and symptoms. So you can see here, back pain. I'm sure if anybody has had, if you have any sickle cell patient here, you have the joint pain, especially in the joints, foot swelling, the arms, also in the arm and the legs. You've got the hand swelling. You see that especially in babies, and then breathlessness, fatigue, and the jaundice, like I said earlier. So, and yep. So how do you diagnose this sickle cell disease? So you can diagnose it, like I told you, before the baby is born. That's what we call prenatal. And you can also diagnose, there's also the newborn screening. So we screen for babies so that they can start giving guidance on how to manage the children who are born with sickle cell. So after that, then if somebody is suspected, if you miss these steps, then somebody is suspected, because I think in the UK, they are really doing well, and it's difficult to diagnose sickle cell anemia in adulthood. So we have very few cases, because most of them are diagnosed when they are born already. So if, for example, somebody comes in, some people are missed, so maybe those who migrate and come here, they don't have the newborn screening. For example, in Cameroon, where it is prevalent, we don't have a newborn screening for sickle cell, unfortunately. So those things are missed, and many people are diagnosed when they move into Europe or into the UK. So the choice of the test would depend on the hospital or the local area, what guidelines they use. So we do what we call a full blood count, which tells you how your red blood cells are, how much your hemoglobin is, that's how much blood you're producing. It tells you what the size of your hemoglobin is, so the MCV, because normally these patients have little red blood cells. So the size of the red blood cells will be a little bit less than what, most of the time is less than what the normal person has. They will have what we call the reticulocyte count, which results from precursors, so blood cells that are produced before hemoglobin, the red blood cells are actually produced. This is simply because we have increased destruction. So the body is always ready, it's always producing because it is always destroyed. So you have a raised count, and in many areas, and I'm sure even in Cameroon, the easiest way is to do a blood film. So you go and they do a smear, they look under the microscope, and it's very easy to spot. You don't even need to be a doctor. If you've read, you can easily spot those sickle cell shapes under the microscope. So they have more specialized laboratory tests also to identify the different kind of hemoglobins, because when you're born, you have the fetal hemoglobin, which is what many babies have in the tummy and when they're born. And then when you grow into an adult, the hemoglobin changes form and it stabilizes, and we have the adult hemoglobin. So the lab has specialized tests to do this, which is just a kind of electrophoresis that just tells you how those chains that I showed you before, how they migrate. So you can see here easily, sometimes you go to the hospital, some of the people are picked up by chance because they go and they realize that you have a little volume, and maybe depending on the area you come from, they might decide they might offer you this test, and they realize that you have the sickle cell anemia or you have the trait. And I'm sure many of us here have come and discovered we have the trait just by random blood test. And so with all of this, what is the treatment? Mostly you have the acute phase treatments, which we treat the symptoms, which is mostly with painkillers. And then some people, because of the destruction, they've got itches and stuff, so you use the antihistamines. And because also these patients, most of them are very prone to infections, so they're giving antibiotics, some of them just as prophylaxis. And then the most important thing, these crises are very common when you are dehydrated. So what they do is these patients are always advised to be hydrated. You're giving drips in hospital when you have your crises. Then you have the most common therapy that they use now, which is the hydroxycarbamide. It is hydroxyurea, which is just a substance. It's a drug that helps to, it helps to increase the flow of blood in the vessels. It helps to increase, some studies have shown that increases the size even of the red blood cells, which helps to carry more oxygen and things like that. So we have new studies like the monoclonal antibodies, and then there are you have the stem cell transplantation. Some studies are still undergoing this, but also some patients I think have already had this in the UK, but they do it very less often because it's a very invasive therapy, and also it's got a lot of complications. So last but not the least, you've got supportive care and the prevention of the complications. So patients with sickle cell should avoid extreme conditions such as extreme cold, because the crises are very common during this time. You know, some of the crises you get it during exercise. So most of them, you're advised to rest when you don't feel well. As I've said earlier on, a lot of hydration. So and also supportive care is like exactly what we're doing right now, making people aware of the disease and explaining and helping them to know the different bodies which can manage this pathology. So that is the end of my presentation. Any questions?
Hello. Yes, Dr. Bennett, thank you so much for a very succinct presentation. I think what comes across is that first you said nature, in trying to address a more serious issue in malaria, has created an even more challenging health condition for us. But again, one of the things we want to see in a conference like this is a message of hope. And you finished off by saying that this can be treated, well treated. You even mentioned that there's a potential cure. I just want to keep people on hold to say that keep sending your questions, because I've seen questions are coming online. We'll pick up those questions during the question and answer session, because they're very valuable. In fact, there's some serious ones are actually coming across. So what I want to say that Dr. Bennett says, yes, there is treatment and there's even a cure, even though the cure has challenges. You mentioned about bone marrow transplant, the challenge being, as you said, essentially the fact that there are risks involved, but of course, it's also not cheap. And of course, not accessible to everybody, especially our colleagues who are challenged, who are faced with the realities, who are not in the UK, in the advanced economy, where they can do some of this bone marrow transplant. But then you did mention that it can be well treated, and in fact, it can be well treated. So we thank you, Dr. Bennett, and we hope you'll be able to join the panel later. I know how busy people are. But meantime, you mentioned it can be well treated, and just an appropriate point to key on to two doctors who are actually seriously involved in addressing sickle cell challenges on people on a daily basis, especially so at the accident and emergency. That said, I have been alerted that when we started earlier on, we did not have the chairman of the Sarah Ayoka Oduwaiye Foundation on, but we understand that he's now on. Is it possible to get him just a short 1 minute to say who he is, or for us to know who he is? Dr. Banji Oyebami, is it on now? Mr. Ofolabi, is it on? We were looking at somebody said that Mr. Oyebami was on.
Yes.
The chairman of the foundation, is he here? Okay, let's move on. We will come back to him. Let's move on. So at this point, I would like to introduce Dr. Kamara and Dr. Obale. And like I said, Dr. Bennett ended on a positive note. That it's a very serious condition. Sickle cell is nothing. It's a very serious condition. Yet there is hope. There is treatment for it, and in fact, there is even going to a cure. There are even recent advances which will come to under Q&A. A lot of recent advances along those lines that Dr. Bennett mentioned. For example, the hydroxyurea, trying to challenge the occlusion, the blocking of the vessels. We'll talk about that when we come to Q&A. But let's look at those who, on a daily basis, two doctors, one of actually deals with this at the accident emergency. We are not forgetting about people in Africa or other places, but let's look at what is happening in somewhere which can also be seen as a beacon of hope that can be cloned elsewhere. So let me pass the microphone. Let's pass the microphone to Dr. Kamara and Dr. Obale. Are you both on? Dr.
Yes,
Kamara,
can you hear me?
Yeah, thank you so much. Please introduce yourself and get we've allocated half an hour for the both of you. Could you please try and put your presentation within half an hour? I don't hope I'm not trying to rush this position, but we are trying to make sure that we keep everybody to time. So Dr. Kamara going on first, and then Dr. Oduwaiye will follow.
Yeah. Oh wait, what is it now? For some reason, I'm not able to share. Am I able to share?
Yes.
Can you hear me?
Well,
Very
I can
well,
hear
sir.
you, and I assume from the technical team that you're on. Everyone is hearing you.
Can you see me?
Yes, I can see you as well, and I assume the technical team are saying we can all see you.
Okay, let's start sharing then. Can you see that? Can you see that?
Yes, we can see you, sir.
Right, okay. So thank you so much for having me. My name is Mr. Mohammed Suri Ibrahim Kamara. I work as an emergency medicine consultant with Dr. Oduwaiye, and I am originally from Sierra Leone. Thank you for having me. What you see here, this title, Well Body Better Past Gentry, is the Creole of a version of a group that I led. And this presentation, as you know, because of the importance and the significance of the subject we are deliberating today, I think all our people need to know about it. And if we can do that in any language whatsoever, in any of the ethnic, languages, tribal languages and all that, I think it's even better than just, speaking in English. So that's why we present ours in Creole. And what this is, it just means health is better than wealth. So I have no conflicting interest in what I'm preparing to present to you. But I normally, when I do my talks, I always start with an icebreaker. And this talk is full of them. My colleague has done well, this previous speaker, Dr. Mbene, and what I'm going to tell you, most of it is repetitive, but probably in a different version of it. So I always ask the question, who's the first to identify or discover sickle cell disease, what we're talking about today? And a lot of people will think this was somebody from the Western world and all that. But in actual fact, the chap who first wrote about the condition in his book, The Diseases of Tropical Climates and Their Treatment, that was published in 1874, very, very long before the Western discovery in 1910, was, was Africanus Houghton. This man, I don't know if we can mute ourselves. If we're not speaking, let's mute ourselves, please. Africanus Houghton, as I say, is the first man to write about this, and in 1874, and it's only in 1910 that Dr. James Harrick actually published his findings. But definition, I think we talked about already. It's a disorder that is caused by an inherited abnormal hemoglobin, that is the oxygen-carrying protein within our red blood cells. As you can see, because of the shape, they're shaped like a sickle. If you look here, this is the normal. When you cut it to half, this is what you see. That's the normal one. The abnormal one, which is sickle one, you can see is shaped like a sickle, hence the name sickle cell. So because the round ones are made for the blood vessels, they flow smoothly in the blood vessels, the veins, the arteries. whereas the ones that are sickle infected or affected, they definitely are shaped like this, and therefore their flow is abnormal. So therefore they're prone to easy destruction, and because they get destroyed, then the person that is sickle cell anemic will probably need more blood transfusions. As we know, the red cells normally replace themselves once in every 120 days. Okay, so 4 months, 3 times a year, that's when you get the normal blood cells to do that. Whereas with the sickle cell, it's definitely a lot more frequently than that. So it just goes to show you that because of the shape, you see the difficulty. As I said, this man was born in Sierra Leone, I'm proud to say. James Africanus Bill Horton, he studied in Edinburgh, and if you go to Edinburgh, University of Edinburgh, outside there, you can see this plaque dedicated to his memory in 1835 to 1883. And then, of course, on the right, you see the Englishman, James Herrick, who actually noticed this peculiar elongation and sickle-shaped red blood corpuscle. And this is what he wrote about in the case of severe anemia. This is in the Archives of Internal Medicine, 1910. So, second icebreaker. I like to go through them. Now, people have this understanding.
Hello, Baba.
There is this belief. There is this belief that only people of African ancestry can have sickle cell disease.
Because
oh my God. Can we mute ourselves, please?
Moving stream live.
Right, okay. I'll carry on then because I know you can hear me. Right. The fact is, sickle cell obviously mostly affects those of African ancestry, but it's also one that is known to affect people from different regions around the world. As my colleague said already, she's alluded to this already, that 5% of the world population harbors the alleles, that, you know, the hemoglobinopathies. I know she explained that very well. It's the abnormality of the hemoglobin, which is a protein that we have in our blood. And 5% of the world population has got this. And about 300,000 children every year are born with these abnormalities in the hemoglobin. And in Africa, as she said already, 200,000 children are born annually with sickle cell disease. I mean, the areas of prevalence, you can see, sickle cell trait is frequently between 10 to 40%. The disease itself is probably less than or equal to 2%. And the highest rates are in Ghana, in Nigeria, and Uganda. You know, but what it tells us is it is found in most people with ancestors from Sub-Saharan Africa. Because of the intermarriages and the migration and emigration and immigration, you now find sickle cell in Sub-Saharan Africa, South America, Central America, the Caribbean, in fact, the Middle East, Saudi Arabia, and of course, Asia, where in India, you know, Mediterranean countries as well, including Italy, Greece, and Turkey. So this is just to tell you what happens. As you can see, North America has got 100,000, Latin America, 85,000, Sub-Saharan Africa, more than 5 million. Europe, as we are now, is 40,000, of course, and so on and so forth. Middle East has got 180,000. You can see what India has got as well. Now, my colleague alluded to this already, to say that the distribution of malaria, the belt of it, as you can see in the diagram on the right, you can see on the left, it's almost mirrors it. It's almost, you know, identical. It just tells you that belt, you know, mirrors the other, which he said already. Icebreaker number 3. There is this myth that sickle cell disease is contagious. I really decided to go into this because I wanted people to understand that this is not contagious. This is not something that when you come close to the person or he coughs on you or sneezes at you, you actually contract it. No, this is an inherited blood disorder. It's one you get either from mom or from dad or from both of them. It is not contagious at all. It can only be passed from the birth parents, not the grandparents, not the great-grandparents, only the birth parents. And it's not anything to do with the curse on the woman or the man. No, this is inherited. It's as simple as that. So how do you get sickle cell? I think my colleague alluded to that. But I thought I'll just simplify it because you can see this diagram is quite easy to follow. If you look at the dad being a trait, a carrier, and the mom being normal. And on the right side, you get both mom and dad being traits, having traits. And you can see what the chances are for every pregnancy. So for the one that has the trait, that is dad and mom is normal, i.e. not having any of that, you'd see that 50% for every, I'm talking about 50% of every pregnancy. It doesn't mean 4 children. This is 50% of every pregnancy would give you a possibility of a 50% of the children being those that have the traits, and the other 50% possibly don't have anything at all. Then, of course, where you have the trait and the trait, i.e. the mother and the father, you would see that you got 50% possibility over every single pregnancy being those that may have the trait, and of course, 25% normal and 25% definitely sickle cell disease. Now, and it continues here. You see that the dad is sickle cell disease, it's got the full-blown sickle cell, and the mom is normal. And you can see that if they have children for every pregnancy, there is the possibility of a 25% chance that the child would have a trait, not the sickness or the illness itself. And on the other side, on the right, you can see that dad has got the sickle cell, but mom has also got the trait, not the fullness, and she's not normal. And you can see that for every pregnancy, there is the possibility of 50% of the child or the children being traits, and of course 50%, the other 50% of the children being the full-blown diseases. So it just gives you an understanding. And it's then the middle one, which is the big one, where you have the mom and the dad being sickle cell, patients, i.e. people that have the full sickle cell. You can see that for every pregnancy, there is the possibility of the child being somebody that has sickle cell. And these are the ones you worry about. This is where you get your screening that my colleague talked about. This is where you got the counseling and the rest of it. So it's important for us to understand how this comes about. Yeah, so that's it. I hope that's clear. If it needs explaining later when we're having the Q&As, you could probably go back to this slide and you'll understand it better. Icebreaker number 4 is there is only one type of sickle cell disease. That is not the case. There's so many of them. There's several types of sickle cell disease, including, but not limited to, the HBSC, that's the sickle cell, the HBS thalassemia, the HBSS, the most common form of the condition are these ones that I've just highlighted to you, but there's plenty of them. Okay, so again, it just tells you which ones they have. You see thalassemia, hemoglobin sickle cell disease, hemoglobins with the beta thalassemia, hemoglobin SD, and hemoglobin SE and hemoglobin SO. You see so many of them there, but the main ones are the ones that I've just highlighted and listed to you. So my colleague talked about this. Now, I don't want to dwell into that, but of course you can see the effects from head to toe. The major features, this is what I wanted to just hop in on, or just home in on that. The major features and symptoms of sickle cell anemia, which he said already, are mainly fatigue, because you have anemia. The oxygen is not carried to the brain and to the tissues and to the oxygen, to the organs. And so therefore you get that lethargy, fatigue, pain crises. This is mainly what they present with to us in the emergency department. Dactylitis in the children, that is the swelling and inflammation of the hands and or the feet. And sometimes this sort of gives rise to arthritis. And of course, definitely you have infections, most of them being bacterial. But of course, because they may be immunocompromised, they may well have superimposed infections, or they could well have viral infections as well. The liver congestion, which results in jaundice, that could manifest itself. The lung, of course, because they're immunocompromised, definitely you have, and because they're, high up there in terms of the risk category, infections of the respiratory system are high on the agenda, because, believe it or not, the lungs are the only organ that actually, I'd say, communicates, that's the word, communicates with the external world we live in by up to 20 times a minute. No other organ does that in the body. And that is why the lungs are very prone. And that is why the lungs are the first thing that will take anybody out of this world. So it's important to remember that. Cardiac problems, the heart, again, if the heart is overworking because of the fact that the hemoglobin is low, so the heart now has to pump the required blood and oxygen and nutrition to the organs, the heart will become bigger because he has to compensate. It's a bit like you go to the gym. When you pump your muscles in the gym, you definitely would get bigger muscles.
You can't park there, man.
All right. Oh my God. Right.
You park there.
Then of course, because the blood supply to the legs is a bit suspect, it's deficient, you get the breakdown of the skin and you get to develop the leg ulcers, because you have the abnormal hemoglobin. And of course, the most important thing is that you have to remember that if the bones do not get the blood that they need, the nutrition they need, they tend to die. That is what we call aseptic necrosis. It happens, a portion of the bone dies, and that causes problems with arthritis. The eyes can get damaged, it causes problems with vision. And of course, it stunts the growth. I've seen children who were supposed to grow very tall, but of course ended up with growth problems because of the crisis they have. The spleen can get enlarged and can be really painful. So in total, you could see that on the right, you see the brain, you get cerebral infarcts like strokes. If it's the eyes, you get retinopathy, abnormality at the back of the eye, the retina, which gives you the vision. You have stone formations in the lung, in the gallbladder, which is cholelithiasis, which again is very painful when it presents. Someone eats any fatty product, it causes problems. In the kidney, you got renal infarct, and of course that can manifest itself as blood in the urine, which obviously is not a good sign. You've got the bone, long bone, which is overgrowing, if you like, hyperplasia of the long bone. And as I said already, the death of the bone, which is not caused by sepsis, so what we call aseptic necrosis. And sadly, that can lead to things like osteomyelitis, which is a very difficult infection to treat. Dactylitis, we talked about, the swelling and the lack of circulation of the fingers, the toes, because of the vasoocclusion, that is the blood vessels getting blocked. You can get, as I said, also already, and the spleen can get bigger. So there's a lot of things, as I say, top to bottom, it affects, So I've said a lot, and I just wanted to give myself a breather and to give you a breather as well and a break. But listen to this video. So there we go. I hope you enjoyed that. That's just an interlude. That brings us to what my colleague was talking about, antenatal screening. It's important. This is absolutely vital. I have a family now here who are half Nigerian, half Sierra Leonean, and there were complications that arose because the understanding was the husband had been checked out, had been, sort of assessed and screened in Nigeria, and they gave him a negative screening test. And the wife here has had a negative screening test. And when they had the children, one of them has got the trait and the other one is a full-blown sickle cell. And that created a lot of problems. So let's be careful. We need to understand that. Sometimes they can, I don't hate to say this, but they can manufacture these tests. And we know how these things happen. And they can risk a lot of problems, a lot of hassles, not only for the parents, but for the children as well. Their future, their employability, their education, in terms of economy, finance, and all that, psychologically, thinking I'm different from the other, stigma, all of that needs to be considered when we're looking at this thing, So it's nice to have, probity. It's nice to have honesty and transparency when we're dealing with these things, So what you have is just a rundown as to what is offered as antenatal screening. You can see it's prenatal means before birth, So you do that, the test of, for sickle cell, possibly using amniocentesis, which is the blood, like a liquid they get from the amniotic fluid in the baby, and or maybe they can use chorionic villus sampling. They can do that. It's obtained and then tested for DNA analysis of the fetus cells. Now, this is just, as I say, follows what they do. When you get the blood sent to the lab for the hemoglobinopathy, which is the abnormality screen, you then get an information. If you've got positive results, then you need information, you need counseling, for the partners, and then the screening takes place. And again, the blood is sent for this partner, again, for the same thing. And when you get the results, if they're positive, again, you then have what we call prenatal diagnosis, people who are at risk, the couple who are at risk. Then, of course, you have the fetal blood sampling or the villus sampling, which they do. And of course, if at all the baby is born and is affected, then again, you have information provided, and of course, you get counseling. So it's important for people to know that they could make an informed choice, and that termination of the pregnancy, which a lot of people don't want to hear about, is just a reality, really. So you're not saying you have to do it, but it's important to consider, whether this is something of a way out. So at least you have all the alternatives, you have all the options available, and you can then make an informed choice. And nobody can tell you, say, well, we coerced you into doing it, but you know exactly what could happen. If you opt to carry on with the pregnancy, obviously you would have readied yourself, you have psyched yourself to carry on with it. Whereas if you don't want to do that, and yet you're coerced into thinking about it and doing it, then maybe you might regret things later on, because it's not an easy burden to carry on with. There's no questions about that. So the test is what this just does. This is just the slide to tell you about the test and what it does, really. I wouldn't delay on that. I wanted to tell you about this. I think my colleague talked about this already. But you can see the picture, a nice, beautiful picture, obviously not for the patient, but you can see in the child. It's important to note that the infants with sickle cell anemia do not develop the symptoms in the first few months of life. And it's important to understand that, because the hemoglobin produced by the developing fetus, which we call fetal hemoglobin, it does have a protective characteristic of the red blood cells from sickling. It's only thereafter, by possibly 6 months to 2 years, that's when you get that. So you have the painful swelling of the hand or the feet, and sometimes that can lead to infarction of the bone marrow due to, as I said, occlusion, blockage of the blood supply. As I said, this happens between 6 months to 2 years. And one thing you do about this is that I hydrate them and you manage the pain nicely. And you can see the difference between the right hand of this little one here and the left hand. You can see the swelling, it's shiny, it's swollen, it's deformed. And on the left, which is normal, you can see the difference. So it's nice sometimes to look at, how things happen. And when you see it visually, you can then be able to relate to it. So in children, we have certain treatments, the signs and symptoms we look for, which, as I say, they're pale, they get tired easily, they get breathless, and they have problems with growth. And later on in puberty, the puberty sets in later than with the healthy children in comparison, And of course, you can treat them depending on what symptoms they have. And that treatment may include antibiotics and, of course, blood transfusion. The little one I'm talking about has to have blood transfusion every month. Just imagine that, every month. Transfusion, that means mom has to leave work, dad has to leave work. If the economy, or not economy, their finances depend on that. Do they have understanding bosses? Do they have, management that understand that, look, this child has to be taken. It's just a matter of this and that. So this is what we need to be making people aware of. So when you prevent that happening, maybe these problems will not be as prolific. And of course, if there are employers, they need to think about how to make things a lot easier, a lot better, a lot family friendly for their employees. We have the hand, foot, and mouth syndrome, signs of which and symptoms of which include fever and pain, swelling, or coldness of the hands and feet. And obviously, the treatment includes recommendation of painkillers and again fluids to treat that, because once that occlusion is gotten rid of, the symptoms sort of subside and they get better. The infections, again, if they get cough, they get fever, they have problems breathing, and they have pains in the bones, like in the chest, which is called the chest syndrome, and headaches, then obviously you need to be thinking about treating them. Are they up to date with their vaccinations? You need to consider giving antibiotics after you would have taken blood cultures. You need to help them, because that would help them to prevent infections from getting really worse, and that can cause problems which can then lead them to death. So between 2 months to 5 years of age, that is when these things happen at most. And that's why you need to be very vigilant and be making sure that you are reviewed, as things happen. Again, the pain and the splenic crisis. This is one thing that people need to know about. The splenic crisis. The signs include pain on the left side of the belly. It is important that when that happens, that is associated with weakness. And of course, the heart rate becomes very, very fast. You know, when they do have this crisis, usually you have to take them to hospital because they will need conservative treatment. And of course, they need a blood transfusion. And at worst, they might need the spleen removing, but that's very rare. Believe it or not, the children can develop a stroke. So signs and symptoms include if they have a severe headache, if they have weakness on one side of the body, you know, and changes in alertness, they become drowsy. You can't speak to them without them being, you know, asleep on you, and their speech is slurred. They can't see, or they have obscured vision, and the hearing is impaired. You need to be thinking about taking these children to hospital right away for treatment.
Dr. Kamara, just a quick point of, just to say that we've got 5 minutes left.
Yeah, it's fine, it's fine.
Okay,
no problem. Yeah. So in the adolescents, you can see that most of it is the pain crisis and the acute chest syndrome, which is quite important. It's a leading cause of death in sickle cell disease, and it's characterized by abnormal chest X-ray pain, fever, and anemia. All right, and of course you get the leg ulcers, and we talked about the septic necrosis already, and the eye damage. Icebreaker 5: is sickle cell a short-term disease or short-term condition? No, although you know many pain crises may be short-lived. People who have sickle cell disease have it at birth, you know, and will have it their entire lives. So this is just the treatments for you. Folic acid you have to think about. We talked about blood transfusion already. There is this business of stem cell transplant, which is very much ongoing now. Of course, the mainstay of treatment is analgesia, and it has to be appropriate. It's not just paracetamol or ibuprofen. You need something stronger. You know, morphine, no questions about that. Ketorolac, those that know it, and of course, antibiotics in the case of infection. You have erythropoietin, which helps with the production of the blood, and hydroxyurea, my colleague talked about that. That's definitely one thing you can use. Magnesium, clotrimazole, when you have antifungal fungal infections, you can use that. And of course, the cell transplantation. And last but by no means least, gene therapy. It's a potential, and it is, I think, deemed to be curative, but it's still in the early stages. So nutrition, I think we'll talk about another time, but this is just something I wanted you to think about. 1 out of 500 African-American births do have sickle cell disease. 1 out of 36,000 Hispanic American births do have sickle cell disease. Look at this, 1 out of 12 African Americans carry the cell trait. So it just tells you that indeed, this is a very, very important topic that we need to get our people to understand what it is about, how they can actually live with it. People think you live for 20 years. No, I know people who have lived up to 80 years because they looked after themselves, because they've got their plan, which they comply with, and they get to the hospital and it gets better for them. No questions about that. These are my references. Thank you very much for having me, and I'll be happy to answer questions on the Q&A session.
Excellent, Dr. Kamara. As they say, 2 doctors saying the same thing differently, but essentially for emphasis, and especially those who may not have who do not know much about the sickle cell anemia disease. Hopefully, they are learning the 2 sides of the same story, bringing a lot of emphasis, and it's absolutely vital. The key message that's come, Dr. Mbene gave message of hope that there is treatment. Dr. Kamara has also given a message of hope that with appropriate support and knowledge, you can live up to normalized life expectancy, which is what we are hoping that we can see how we can ensure that normalized life expectancy doesn't only exist in Europe and America. How can we do that in Africa? But this is what this conference is about. Thank you very much, Dr. Kamara, and I'm very grateful that you've offered to stay on for the Q&A. Can we now have Dr. Obale, please? Dr. Obale, are you on? Mr. Afolabi, can we have Dr. Obale on, please?
Yeah, are you able to speak up?
No, I'm just waiting for my slides to come on.
Yeah, the slide.
Okay. Hi, everybody. Good afternoon, everybody. I'm just waiting for my slides to come on. I'm Dr. Ayoka Oduwaiye. I'm a consultant physician at the Testify General Hospital, and I feel honored to participate in this webinar. And I'm just waiting for the host to put my slides on. Afolabi, are we there? What happened? Or can I share my screen?
You can.
No, but it's on.
It's coming on.
It's on now. Can you can't see it? Okay.
Share screen.
Share screen. That's the way we share. Could you share? Everybody can see them. I can't see the screen.
Okay, just a moment.
Oh, look at that. That's what we're showing. Okay, so we need to find, is it this one? Sickle cell?
No.
It's not that one.
Just hold on.
Send it. Can Afolabi show it?
Is Afolabi there?
Yes, I've already shared it.
Have you shared it, have you?
I not see it.
Yeah.
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 Okay. We're gonna. Can you see a sickle cell?
No, it's not that one. It's really the second one.
This one.
Yeah. Okay. Can you see?
Maybe because you're also trying to share at the same time.
Okay. Go back to the website.
So let me share alone because it's a multiple sharing permission. So let me share now. You will be able to see.
We've just done something. Can you see your presentation?
Okay.
Oh, there you've got it.
Are you seeing it?
Yeah. So we'll be talking about sickle cell disease. I'll try not to go through the same things that my two colleagues have already said. Could you go to the next slide, please? So with sickle cell disease, kind of as you would know, it affects lots of areas in the body. Almost everywhere is affected, and most of the care for sickle cell anemia patients is in the outpatient department. And a big number of people involved: general practitioners, specialists, sickle cell nurses, pediatricians, hematologists, surgeons, and lots of other people are involved. In the UK, we have quite some protocols for the management of sickle cell disease. And the patients normally have an annual review and regular clinics by with specialist teams and other teams to make sure that the patients do not have long-term problems. Next, please. So kind of, as we know, kind of there's a diverse group of people who have sickle cell disease, and it's important that our kind of healthcare personnel are updated, because in some areas you may not see sickle cell disease patients, while in the big cities you always get them. I think looking after sickle cell disease patients promptly gives a better quality of care, and the ED departments usually manage most of the sickle cell patients, and they get discharged from the ED. And it's still important that we kind of work the doctors and teams, they know much about sickle cell disease patients to get good outcomes. And we know that the surgeons, they are very particular, they've got very robust protocols. Next slide, please. Next. Okay, so I'll talk a bit about acute care. So acute care, it's important to know that most patients, when they have the acute sickle cell crisis, at mild and moderate pain, the patients usually manage this at home. We've got simple analgesia, the weak opioid analgesia, and patients will normally kind of have other supportive care measures that they kind of use, like kind of plenty of fluids and rehydration, rest. But only the patients who turn up in hospitals are usually patients who have severe illnesses, and very often, as we know, they get IV morphine. Very often, if possible, it's important to know if the patient has got a management plan. Then it just helps kind of guide us on how much opiates to give them, and it just helps to make sure that they get their care quicker. It's important to know that Afolabi is sharing the old slide. Anyway, kind of let's continue. So we'll have to kind of get the slides moving much quicker, because those are the slides. So very often it's important that patients with sickle, you could you could put on the old slides and I'll just continue talking.
Okay.
Patients with sickle cell anemia, if they have taken some medicines, they've done supportive care where they've rested, they've had some fluids, they've had their regular analgesia, or if they realize that this pain is much different from what they have been used to, then they usually call the ambulance team to bring the ambulance teams. And very often, the London Ambulance Service, I think in 2017, advised that patients with sickle cell anemia, when they call the ambulance, it's important they mention that they have sickle cell and they're having a sickle cell crisis. This is because sickle cell crisis has got to be treated as a medical emergency. It's important to know that lots of the sickle cell crisis is because of the sickle cells blocking blood vessels. And when the sickle cells block blood vessels, then it reduces oxygen supply to muscles and different parts of the body. And that could have long-term severe consequences. So these patients by telling the triage nurse at the entrance of ED or the ambulance service on phone that it's a sickle cell crisis, it makes it be addressed as an emergency, and sickle cell crisis should be seen as a medical emergency. So normally the guideline expects that when patients with sickle cell anemia present to hospital, they should be getting their analgesia, that's the strong analgesia, within 30 minutes. Normally we know that's within 30 minutes, and all the patients should have their analgesia titrated till the pain is gone. And this so which means every 30 minutes the patient should be assessed. And if the patient needs multiple doses of IV morphine, then these patients could be considered to for patient-controlled analgesia. So it's also important to realize that when patients come in, lots of the patients could be dehydrated. So it's important that they get properly hydrated. Patients with sickle cell disease, they need to have about 3 to 4 liters of fluids a day. And sometimes when they're very unwell or they're vomiting, they do not get enough fluids. That causes dehydration. That could make their sickle cell disease go back. And it's important to be aware of the fact that patients with sickle cell disease are not able to concentrate their urine appropriately. So, which means they pass large volume of dilute urine, and they are very likely to be dehydrated. So, if they're very unwell, it's just it's important to encourage them to drink plenty of fluids. But when they come in with acute severe crisis, very often giving them IV fluids is part of the good practice for managing these patients. Also, patients with sickle cell anemia, they hypoxia, low oxygen levels, and cause crisis. And we've already talked about blood vessels preventing oxygen from getting to the organs. So then when patients come in, the guidelines here says that anybody with oxygen level of 95% or less should be on oxygen. So very often we'll put them on oxygen, and if lots of patients, even though their oxygen levels will be in the normal range, they seem to benefit significantly from giving them supplemental oxygen, which is part of good practice. So lots of the things to emphasize on good practice about the risk of these patients being dehydrated, the importance of giving them strong analgesia, and we know if we know what their patient plan is from previous admissions, then it is very likely that the starting dose of opiates analgesia, such as IV morphine, will be an appropriate dosage rather than starting them on a small dose and doing multiple doses. Though it's still good to titrate the doses if you're not, it's a patient that's not been seen before in the unit. But it's also good to monitor all these patients who have had morphine to make sure that they get we could identify any side effect of opiates. And we've already talked about the discharging patients with with acute sickle cell crisis appropriately. So I'm not going to talk so deeply. I just want to mention certain things about the complications. We know patients with sickle cell disease could have. What's happening?
Okay, these complications.
Okay. So if we have for some of the complications, for the renal patients could have some bleeding from the kidneys, which we've already talked as hematuria. It could present as pink, urine being a pinkish color, or they could have frank bleeding from the kidneys. Usually, if it is just pinkish urine or mild bleeding, just plenty of oral fluids, IV fluids would kind of sort this out. But in some situations where they're having significant bleeding, this could kind of cause clots and obstruction. Patients will need to be in hospital. They will need special investigations and may need some urology input. Some of these patients will need some blood transfusion as well. And patients with sickle cell anemia, if they're dehydrated or if they go on certain medicines for a long time, like non-steroidals, ibuprofen, naproxen, that could cause some kidney damage. And sometimes this could be picked up when they get the annual reviews by showing that they have some bit of protein in their urine, or their kidney function with creatinine, in fact, is at the normal range. And one of the things I mentioned, that they are not able to concentrate their urine. Many patients with sickle cell anemia usually have very good kidney function, and their creatinine, which is what we kind of measure on how well the kidneys are doing, is usually on the lower side. And if patients start having protein in their urine test on the annual review, we try to protect the kidneys by giving these patients, by ensuring that the blood pressure for patients who have protein in their urine is less than 130/80. Next slide, please. Next slide. Okay, so anemia, we know patients with sickle cell have got anemia. It's a major concern. Their red cells do not last as long as normal red cells, only 20 days instead of 120. And I think kind of with patients with anemia, we've got to kind of look out in case they have very severe anemia coming on, they're very unwell. They want to be thinking about possibilities of problems like kind of parvovirus, which is a virus that will cause severe complications with anemia and aplastic crisis. And it's kind of, we know that patients with sickle cell anemia, that should be on long-term folic acid. And lots of patients with anemia need recurrent blood transfusions. But things kind of, it's not all doom and gloom. Lots of things have improved recently. We've talked about hydroxyurea, which is one of the medicines that we use in sickle cell disease. Patients who get recurrent anemia or who have kidney problems, or patients who get more than 3 acute sickle cell crises a year should be considered for hydroxycarbamide. It's also called hydroxyurea in some countries. And this has been so good in that it prevents the sickling of the cells, improves the total hemoglobin level. And I've kind of known of patients who have been on this treatment. They've not had any sickle cell crisis, any significant sickle cell crisis for the past 4 years, which means they've not had to come to hospital. They've had the minor painful crisis that usually would result in sleep, rest, fluids, and just simple pain relief. And that has really improved their quality of life, and they're able to kind of work properly. Some kind of have been able to get married and this. And so we know kind of it's quite important. For the next slide, please. And it's quite important, next slide. It's quite important to encourage people to register kind of to be donors for sickle, for blood transfusion, because one of the things we realize is sometimes when we get blood donors who are from African origin, it looks like the match for the blood transfusions seem to be much better when it comes to people with sickle cell disease. So I want to encourage as many people as possible to register with blood donors. For sepsis, most of the patients who got sickle cell disease, because their screens are not working adequately from the recurrent blockage of the blood vessels in the kidneys, they are more susceptible to bacterial infection. So these patients normally should have their vaccinations, and that is the prophylaxis penicillin V, and that is one of the reasons why it's important all the patients are registered with the general practitioners who ensure that these patients get the appropriate treatments. Next slide, please. Next slide. I think I've already talked a lot about hydroxycarbamide. Can you go to the next slide, please? And next slide. And next slide. So that is just kind of the slide that just went past was just, and the next slide. So just to tell people that hydroxycarbamide has been very effective in the management of sickle cell crisis. And for patients for the annual review, it's a very robust program. It covers kind of the patients have been checked for all the possible complications. They may have MRI scan to look out for if there's excessive liver kind of accumulation in the liver or in the heart. They test their kidneys. The annual review is quite robust. And I think people who manage sickle cell disease, they may kind of take copies of this just to help guide them and make it easy so that it's more of a tick box exercise, exercise. So it just makes things that things do not get forgotten, and it could help. So I think on a kind of note, as Dr. Kamara said, most of the patients with sickle cell disease, it's about encouraging them to know how to prevent things that cause crisis, ensure that they're well hydrated, they avoid sudden change in temperature, kind of going from hot to very cold temperature, kind of eating properly healthy diet, avoiding overexertion. It's something to mention that they should avoid overexertion, ensure they get enough rest. And I want to mention that patients with sickle cell anemia should try to be involved with the sickle cell societies, sickle cell advocacy group, sickle cell patients and parent support groups, and all those support groups. Because having sickle cell disease, although we talk of 15 to 20,000 people in the UK having sickle cell disease, it could be quite lonely and isolating, because in some areas they may not know anybody with sickle cell, they may be quite isolated. And it's important to know that patients with sickle cell, because they have this struggle that goes on every day, they may feel depressed, they may need some psychological support. And when it comes to getting jobs, if they've made relationships by getting in touch with the Sickle Cell Society and the advocacy groups, they will have lots of information, and that will help inform their employers to make sure that they get some support, that they need to have some rest, they need to have toilet breaks, they need to have their shifts in such a way that they could have time to go for their appointments and for their appointments. It's also important to realize that patients with sickle cell could have long-term chronic pain problems for which they may need to be managed in the specialist pain clinics, and they may need to have some kind of counseling and lots of training on how to manage their pain. And it looks like there will be lots of questions I'll be taking from the Q&A. I hope.
Hello. Hello, we seem to have lost connection. Mr. Folabi, can you confirm that the line is still on?
The line is on, but it's muted somehow.
Yes. Dr. Oduwaiye.
Doctor, please, can they unmute?
Dr. Oduwaiye, can you hear us from your end? Hello.
Yes, we're hearing you, but I'm not sure you are hearing us.
Okay, yes.
No, we
can hear now.
We lost the last minute of Dr. Obale's presentation, the last minute.
Okay. Well, we thank her very much. She did a good justice to it, and we leave it back to you, Chief, in Edinburgh.
Okay.
Yeah, thank you.
Back.
Dr. Obale, have you finished?
I'm finished. If you want me to continue, I can continue.
Let me just say that you absolutely nailed it, because it is important that the two physicians before you have actually emphasized different aspects of the condition, the pathology side of it, and now you have absolutely addressed how to actually treat it from albeit from the UK perspective. But it's important that for the benefit of our lay audience who may not be physicians or clinical scientists, two expressions, they always talk about treat and cure. It's important people should be very clear. When we talk about treating, we are looking at how to modify the illness so that the person can live with it. Then when we talk about cure, we're effectively making it in such a way that the illness is actually wiped out, or at the very least, converting them, in this case of a genetic disease, you're converting them from being actual sickle cell sufferers to become carriers. The carriers live a fairly normal life with sickle cell disease. Can I just point out that I'm saying this because you saw the intervention that Dr. Oduwaiye was actually addressing relating to all the pointers that came from Dr. Kamara and Dr. Anambene. The pointers were there. When you heard about the hydroxyurea, those are all disease modifying. You heard about the bone marrow transplant. That is a curative approach, by the way. Bone marrow transplant is curative. So it's important that we make people to understand this. That I think the message again of hope is that yes, it is a serious condition, but it can actually be treated, and in fact, there's already cure. And being a genetic condition, it is not surprising that there is a lot of avenues of genetic intervention to make sure that it's actually cured. And that there's gene therapy that's in the horizon, and in fact, some successes have been mentioned. We just did not want to convolute this particular presentation by making sure that we give some sort of general perspective of it. But those who would like to know more, during the question and answer, and even after this, we will take things on a one-to-one basis to give people as much information as they will want, and at a level which they'll be able to absorb it. We're not being patronizing, but want to make sure that people benefit from what is coming across. So I want to thank the physicians who have intervened so far. We thank Dr. Anambene, we thank Dr. Kamara, and now we thank Dr. Oduwaiye. So this is now the part that I said that we're going to address the medical aspects. We're going to have an interlude so that those who are lucky to be with you there in London can have some Cameroon jollof rice. And those of us who are out here can also have ours by WhatsApp or by Zoom. But after the musical interlude, we're going to then have Dr. Oyebami again, the chairman of the SAOF Foundation. I hope by then he'll be available. So the musical interlude, I will leave Dr. Yinka or Oduwaiye to actually introduce the presenters of the musical interlude. Dr. Oduwaiye, I hope you are hearing me. So can you introduce me? Yes, well, important for you to introduce. I understand that the team is already there.
Yeah, thank you very much. We have our good friend here. Are you seeing me? Are you
I can see you.
Good.
Yeah, we can see him as well.
Izo the musical is one of our patients here in the practice, and he suffered to come in today to entertain us while we eat our jollof rice. Welcome. Thank you very much. Yeah, they will. You can go downstairs for your own.
It's my pleasure for me to come before all of you today. Yes, I'm going to face them as well. It's my pleasure.
Face the audience, sir.
Well done, sir. I'm right here. I'm going to get to you people. Let me welcome to my people. Let me welcome my people here. So what we're going to do is that, I'm in the music industry. You are all in the medical industry. Like as a musician, we use equipment and everything. So this is another thing I want to do without instruments and all that, but God help us. So we are going to do this together. Right now, we are here. I'm from Nigeria, and I know that for people from Cameroon, Zimbabwe, maybe British, Indian. So what am I going to say? We are all one people. Our own generation, we don't need war. We want peace, we want good life. That's why we have medical people here taking care of life, supporting life, instead of ammunition. Am I making sense? So I'm going to try as much as possible. We're going to sing together. I'm going to teach you people the chorus. The chorus is, we are one people. Can I get it? We are one people. It doesn't matter where you're from. No, we are one people. It doesn't matter where you're from. We are one people. It doesn't matter where you're from. We are one people. Okay, let me teach you again. You all need to respond. We are one people. That's what I say. So, but I will take it now. Now, it doesn't matter where you're from. We are one people. No matter where you are. We are one people. Your color doesn't matter. We are one people. Different color, one people. We are one people. It doesn't matter where you're from. We are one people. No matter where you are. We are one people. Hey, your color doesn't matter. We are one people. Different color, one people. We are one people.
It's just the lighting in the lighting. Yes, the lighting in there is so poor that we cannot see him. The lighting. Just tell them to get the lighting a little bit clearer. Let him. Yeah. No, what I mean is the guy who is singing, they need to face the light to him, so we're not seeing his face. Just tell them that they need to either face the light towards him so that he's brighter. Okay, dear.
Next time it's going to be back to back with food. And that's what we're going to do. I have to travel the whole, they have strikes. Everybody, I have to manage myself. I have to be here because we are one people. And I want to use this medium to thank all the medical doctors all over the world. You people are doing great things. I wonder why they are producing ammunition. They should stop producing ammunition because we are all one people. Why are they producing it for? For what? If there's no ammunition, there'll be less of crime. So please, we are all one people. Peace and love, everyone.
We'd love to have you again. Thank you very much. He struggled to get here all the way from Midlands today with the strength drive. So we thank you because there's really a lot of problem with the railways. So you are still able to come. So we really appreciate you and thank you very much. When we get your nice food downstairs, we are all one people. God bless you all. Thank you very much. It's time for food now. Thank you.
Hello, Mr. Folabi, can you hear me? Mr. Folabi?
Very well, sir.
Yes, I just want to take this advantage to say thank you so much for the job, wonderful job. And through this to say to all those who are actually logged on that please go onto the chat and leave questions because we are actually going through the question now so that in an organized way so that when we come to the Q&A session, we will then have a more organized presentation or responses to your questions. So please keep them flowing. We are actually watching the chat forum, the chat room. There are a lot of questions coming through. So please don't be disappointed that we're not answering, but we're actually noting all the questions. So keep them flowing. We're actually noticing them. Okay.
Okay, sir.
Thank you so much.
Yes, sir.
At the moment, we have about, it's over 50 people linked in, which 50 links, and 50 links suggest from experience that you're talking about at least 100 people who are actually following.
Yes.
From 50 links, at least 100 people are following. So that's well done. And we hope they will also carry these messages, the message from here to the rest of those who could not attend for one reason or the other. So that's very helpful. To keep them flowing, keep your points coming through. I noticed that my colleague, Ms. Arechi from Cameroon is also online and is captioning as usual, monitoring. Ms. Arechi, I hope you're actually flooding us with your questions as usual so that we can be able to pick them up when we come to Q&A. So yes, we are noticing and people are asking questions about hydroxyurea. Questions are coming through about profiling, in terms of how can we profile so as to manage the disease, to modify the disease intensity from amongst various people. we are picking all this, we are noticing all of them, and we'll come to them when we come to Q&A session. Cumulative use of antibiotics, we are monitoring. Just keep the question coming through. The experts are actually reading this, so we make sure in an organized way we'll come back to answering them. Okay, it's yes, we're noticing questions from any questions. People are asking why Nigeria, Ghana, and Uganda have the highest rate. We were noticing all this, and point of correction that Europe has 52,000 people in Europe actually living with sickle cell disease officially, and unofficially they think that figure could, the real true figure could be up to 70,000. We're getting all this coming through, so we are noticing all the comments that come. Please go on the chat room and leave your questions. Yes, the thing about probability of transmission from parents to children, that is coming up strongly. We'll pick that up. And I want to thank again Dr. Kamara for what, and Dr. Bennett, because they did touch on this very vital topic of transmission. And we'll pick that up again at the Q&A. So, okay. Yes, let me pause and also have my own jollof rice all the way from Edinburgh, where I'm actually monitoring this. Thank you all so much. We have, again, the numbers, the links, and the participants increasing. This is wonderful. Okay, so we've got another 5 minutes, and then we should be back on live with our conference. Another 5 minutes. So quick, those who want to rush to the toilet, they should do that quickly. Go to the toilet and come back, because in 5 minutes we should be back on air.
So you want to sing again? People are back in the room now. You've got their jollof rice. I can give us another song. Yeah. Yeah. As you eat your jollof rice, we hear the new music from Yuzo the Musical. Thank you very much. Yeah. Thank you.
Can I see your hands?
Yeah, we are waving our hand. We are waving our hand here. We are waving our hand. Yeah.
I hope they did not have too much pepper soup.
No, they are we want to hear from you. Yeah, we are waving our hand. We are all waving our hand.
Still same song. Yeah. You know, if you're healthy, you are happy. Health is wealth. I remember last 2 weeks I was traveling and Dr. Oduwaiye called me and he said, they need my attention here. And I said, sir, I have a show outside London. He asked me a question. Is your health more important than the event? I remember my friend Papa Wemba died on stage. That's what I'm saying now. Everyone has to be healthy. Healthy people, happy people. Now, make the world a better place for you and me. Let us live in peace and harmony. Happy people, happy country. Children of the generation, let us love each other. Yeah. No more killing, yeah. No more fighting, no xenophobia. We don't want to shed no blood no more. It doesn't matter where you from. We are one people. No matter where you are, we are one people. In your color doesn't matter. We are one people. Different color, one people. We are one people. It doesn't matter where you're from. We are one people. No matter where you are, we are one people. Your color doesn't matter. We are one people. Different color, one people. We are one people. Peace and love, everyone. Next one will be different. We're coming with full instrument. We shake everywhere. Put on your dancing shoes. Thank you, all the medical doctors all over the world. You are saving lives. Peace and love. Thank you, sir.
Thank you. Thank you. Thank you very much. God bless you. Thank you.
Bon appétit tout le monde. Bon appétit tout le monde. That is, this one is, bon appétit is Calabari for enjoy your meal. For those who are, I know you're all Yoruba there, so you're all Yoruba in there. So in Calabar, we say bon appétit, if you believe me. That is French, by the way. That's French for enjoy your meal. So we are about to, we'll give another couple of minutes and then we should get going. Yeah. I think in retrospect, what we could have done would have been during this moment to have some slides actually running through. Mr. Folabi, I hope you've got them, the slides to the patient group all set up. The slides to all the patient group, I hope you've set them up because we're coming to that session now.
Yes, sir. Which one is next, sir?
No, the patient groups, we're going to start with, according to the program, sorry about this, let me just quickly call up the order of events. The first one is going to be from, we're going to go to the two speakers from Ireland, the patient groups in Ireland. But no, sorry, before that, we have to start with we finished the musical interlude. So we're going to have Ms. Damilola. And then we have Ms. Damilola Ajibade. Then we're going to have Mrs. Dorothy Ansah. We then follow that through with the 4 patient groups, which is two from Ireland, 1 from the UK, Uganda, and I think 2 from Cameroon, actually 6 in total. So if you put the slides in that order, the first one will be Miss, I don't know if Miss Damilola Ajibade actually had some slides. If not, then she would do an oral presentation and then we move on to Mrs. Dorothy Ansah. So did we have any slides from Miss Damilola Ajibade? So, okay. Anyway,
yes, we do. Sorry.
Okay, so yes, we did. We have slides. So, Mr. Folabi, if you can just get the slides ready for Miss Ajibade, so that once we come straight away, I just want to make sure that I hope people have, those who were finishing their pepper soup, I hope they've been for comfort break so we can start getting ready. I understand that. Dr. Yinka, are we okay with those in the conference center? I hope people are okay over there.
Yes, we are okay.
Excellent. Okay, so let's go. So welcome again, everyone, to the next part of our wonderful initiative, which is the Sickle Cell Anemia webinar. It's a hybrid webinar. It's a hybrid conference in the sense that there are some people based at the conference center in London, and then people are following all over in across Africa, the US, UK, Ireland. And this, so far, we have touched on the medical aspects of sickle cell disease, sickle cell anemia. I hate to use the expression disease per se, because disease is very technical, but let's consider people who are actually living with the challenge that is called sickle cell anemia or the other forms, as Dr. Kamara himself actually did say. So I'd rather talk of people living with sickle cell because of the nature of the social justice concern that is involved. Now, specifically, we've addressed the medical aspects, and as we know, as the three experts have so far told us, it starts from the medical and extends into affecting the personal life of the individual, including their activities of daily living. Then from the individual, it affects the family. From the family, it affects the community. The community affects the nation, and then globally. But again, as we know, it can be well controlled in as much as there is a cure, but the cure is not available right across at the moment, but there is a cure, and there are a number of other curative initiatives actually happening with regards to how to address the genetic challenge that is at the origin of it, that leads to this blockage of blood channels. Now, but we know, because it creates all sorts of issues, there are non-medical challenges. And this now leads to what I said earlier, that this is a challenge, that's illness is in a way, it's the medical world's own opportunity for us as a Black and minority ethnic community to show that we can take a challenge to world-class level. The challenge comes because social justice issues result from some of the issues that people living with sickle cell actually have to face. Some will face stigma, some will face discrimination, some will face even personal issues where some they tend to withdraw. Whereas we know that, just like the medical side where we had advances, some of the things that the doctors are doing, even out there on the community side, the social justice side, there are a lot of things that are actually happening. So what we want to do on this part of the thing is look at the triumph of the determination over the adversity that people are actually facing, the triumph of determination that people are facing on how determination is linked to triumph. And so we're going to go through some personal stories. Then we now move on to social justice groups. We should talk of them as patient groups or NGOs. And then at the end of that, we will now come back with some response. Myself and some friends from Great Ormond Street Hospital will actually come back. Great Ormond Street Hospital for sick children in London. We're going to come back with a response, as it says. But let us now, first of all, start by listening to this a young lady who, living with the challenge of sickle cell, it impacted on her life, and she decided to do something about it. And when she do something, it sounds a cliche, but she actually did something serious about it. So at this point, I would like us to pass the microphone to Ms. Damilola Ajibade, who is, she actually has the Damilola Sickle Cell Foundation. She actually created the foundation, and she'd like to tell us a little bit about it. We are trying to, because we have a number of patient groups, we are trying to limit this to about just quick 5-minute presentation each, please. So Ms. Damilola, please, you have the microphone.
Thank you so much, sir. Good afternoon, everyone. I'm Ms. Damilola Ajibade. Now I'd like to thank Sarah Ayoka Foundation for giving me the opportunity to be here. So I own an organization for sickle cell, which I term Damilola Sickle Cell Foundation. It's actually a non-profit organization that is dedicated to spreading awareness and enhancing the well-being of sickle cell patients in current states in Africa as a whole. And our foundation also has been indeed creating awareness on measures to mitigate the spread of disease and helping on sensitization campaign to educate people about what sickle cell is and to help members that have family living with sickle cell. We are also growing number of sickle cell patients in Kwara State, Nigeria, and we are a support system that is willing to support any patient in Kwara State, any sickle cell patients living in Kwara State. And what we do in our foundation, sorry, I'm giving limited time as I'm rushing. What we do in our organization is that we offer free medical treatment for sickle cell patients, inquire free drugs, counseling, and consultations. We also offer assistance to people living with sickle cell. And we carry out community-based sensitization where we go to communities in Kwara State, local government. We go to various local governments to tell people about sickle cell. Hospital visitation. Currently, we have patients in the hospital under our foundation that are in the hospital, and we have volunteers working for us that pay visitations to them. We also distribute sickle cell educational materials, just more like a pamphlet or something, just to let people know about sickle cell. And we offer advocacy to carriers and their family members. You know, most people living with sickle cell doesn't even understand what sickle cell is. And we also provide ongoing management service, home services, and all of that. Our mission is just that we want to focus on creating more awareness. Like our previous doctor said, African has the highest number of people living with sickle cell. To say Nigeria is part of the people who have the highest number of people living with sickle cell. So we work more on awareness and advocacy, mass orientation, symposium, sensitization. That's what we do. We also work with healthcare services in Kwara State. That is the Ministry of Health in Kwara State. We work with the Commission of Health in Kwara State, and we also work with the Kwara NGOs we have in Kwara State. We foster and sustain community sickle cell persons. So we sustain them with different contributions to people living with sickle cell. And our mission is to make sure, our vision rather, is to make sure that we get rid of the spread of sickle cell. We know we cannot do that at once, but we are hoping that one day we can limit the weight of the highest number of people living with sickle cell in Nigeria, especially. So we are aimed to create affordability to materials, aims to bring ease to their pains and without the fear of stigmatization, because of course, Nigeria, we stigmatize people a lot, and that's because of ignorance. And we don't take it as an offense when you stigmatize people living with sickle cell. So so far so good. The Sickle Cell Foundation has numerous achievements. We have done so many programs and sensitization programs, and one of it is like there was not any other sickle cell fund state, and this is one of our achievements. And we also had the first sickle cell patient and first sickle cell NGO in Kwara State, because we realized that a couple of our sickle cell patients need blood constantly, and we are glad to say that we have over 60 registered blood donors in our organizations. We also launched the first sickle cell laboratory in Kwara State because we realized that the more patients we have, the more the bills on us, and there's no fund coming in. So we decide to bring up a laboratory for the sickle cell where they get tested every month. We offer free clinics to them every third Saturday of the month in Kwara State. So we also did a foundation that we are recognized as the best sickle cell NGO in Kwara State, and we are also back then award a couple of times, 3 times in 2 years. And we have also saved warriors' life, 2 warriors' life, on an account of one person living with leg ulcer and on account of person living with avascular necrosis. So we are also into giving us free genotype test for free. I mean, in Kwara State, we have a particular month. Thank God, September is Sickle Cell Awareness Month. So during September, we share, we have free genotype test for the test, and we have visited materials, food items. Beneath it, we have pictures that demonstrate what we have done. I'm just talking, we have pictures to back up our IT. We have a couple of things we have done. Yeah, okay, so this is our blood bank. We have a couple of bloods in our foundation where warriors come and we just tell them to get tested and give them for free. We also have we have the Commissioner for Tertiary that visited our center for sickle cell genotype tests when we were offering sickle cell genotype, and that is our sickle cell laboratory launch. We launched it and people get access to free medical treatment. We also share materials, food, drinks to people in some local governments for upkeep so that they can, because most people live in hunger, they use drug without eating, which is not appropriate. So we also help them. People get tested for genotype and all of that. So that is what we do in our foundation. We cannot display all, but we have so many things to do. You can also actually check us on our social media handles for more pictures, for more of our events of what we have done. You can just check through Damnola Sickle Cell Foundation on Instagram, Facebook, and Twitter at the Sickle Cell Foundation. So that is what we do. Thank you so much.
Fantastic job. This is what I like about when it gets to listen to what patient groups or stakeholder groups like what you're doing, because like I said, it's an issue of the triumph of determination over adversity within the framework of social justice. You're addressing activities of daily living. Look at the fantastic results that you've just been listing. Now, I hope as the day will go through, we will then end up in such a situation that you will begin to see some avenues how they can come to support your work even more so that you can do more of what you're doing. I suppose when we come to Q&A, some questions might come your way. But meantime, let us move on to the next speaker. And this is essentially the challenge of within the family. So the family sickle cell story. We have got Mrs. Dorothy Ansah. I think Mrs. Dorothy is actually right there in the conference center in London. Dorothy, are you there?
Yes, I am.
Wonderful. Okay, so we've got you. Mr. Afolabi, did we have anything to put on the screen, or we're just going ahead?
No, she doesn't have a slide. She's just going to do a verbal presentation.
There you go. It comes straight from the heart, and that's what we want to hear, the genuine stuff. Yes. Okay, so we've got some 5 minutes for you, and please tell us, and then hopefully, we hope you're not going to rush away so that you can be at the question and answer session as well when we come to that part. So thank you so much, and you have the microphone.
Okay, hello all. My name is Dorothy Ansah. I am a mother of 2 sickle cell children, and the experiences of being diagnosed with one, I'm a carrier and my husband was a carrier, just like the doctors have explained, is something that is given by hereditary. So I am a trait AS and my husband was an AS2. So we ended up with 2 children that have sickle cell disease. I have 3 children in total. One of them is a carrier, while the 2 are blown sickle cell diseases. It's been experience from them at birth was quite hard. It's not something that you have to tell somebody about it. It's something that you just go into it. But we have things like this stigma where I had to call my family back home to say my kid had sickle cell. The first thing was it wasn't possible. Then you are now stigmatized. Don't say anything about it. Don't tell anybody about it, which looking at it now is something that there's no how you have sickle. If you don't talk about it, you don't share about it, you don't read about it, there's no how you're going to move forward. You've got to learn more about it to understand it and give your kids the survival rate, which I did. I brought up my children to be able to know their sickle, to be able to attend every, just name it, anything on sickle, so that they would be aware of what sickle is and how to manage it. It hasn't been an easy road. They had lots of transfusions. They used to be on admissions together in the same ward, different beds. I just have to shuttle through that bed and that bed. Keeping up a job, whoa, it's hard to keep a job on. but you just have to manage to keep the job on. It's not easier, as they say, when they are kids, you can control, you give them their medications. They all had their vaccinations. I don't miss that. All their hospital appointments, we never miss them. They had lots of blood transfusion. Both of them don't have spleen. They had to take out their spleen before they were 10 years old. My boy almost had stroke, 75% occlusion. We ended up in the stroke team for over 3 years, taking lots of antiplatelet to try and stop that. He has antibodies in his blood now, so he cannot be transfused, which is something that's really hard. So he tends to be quite ill, goes to hospital often. They are, both of them on hydroxyurea currently. It is not an easy thing, but you just have, as a parent, wherever you are, wherever you are listening, you can do it. Just lots of encouragement. You've got to talk about it. Please don't be silent. That stigma, if you don't break forth, you will not be able to know. And remember that bringing up the kids, you would have that issue always at the back of your mind, them saying they shouldn't have been born, because remember that it is a disease or it is a condition that is being given by both parents, and they are aware that you had options to terminate that pregnancy. So you have to be ready. You have to attend psychology classes. You've got to let them speak out whenever they want to speak out, because in their own aspect, it's quite frustrating for them. So you have to allow them, but at the same time, as a parent, you have to be open to be able to answer any question honestly. They have the question, how old do you think we are going to live? And no one lives above 30, or no one lives. So you have to be the one to try to explain that you can do it. You've got to listen to yourself, take your medications. They are above 18 years now. When they were younger, I could give them their medications. Now you think you're a bit free, but I tell you, you're not. You've got to remind them, have you taken your medication? They get quite angry that you're asking them that. But as a parent on your own side, you've got to ask these kids, have you done this? And there'll be a time, I know you have to stop, but you have to make sure and try and encourage them as much as possible for them to take their medications. But that will only be done if they do understand why they have sickle in the first place, and if they can talk about it. So the red flags for me is if they don't talk about it, if they get angry at you at nothing, then that thought comes to them, you would have done something instead of giving birth to me. So you've got to be open, you've got to talk to them. Yes, I still keep my job. Yes, I am still working. Yes, I did work throughout when they were kids till now, but it was only because I was open. I told my managers where I was working, so they did understand. I had a plan in place where if they are sick, I go off, not sick, I won't go off sick, but I will take my days off. Then when I come back, sometimes I have to forfeit my days off, my annual leave, to try and put back the timings I've taken off just to look after my kids. So it's something that anyone around there, just be aware of it, but you can all do it. Thank you very much for giving me this.
Wonderful. You see, this is why, like I said, this slot is going to deal largely with the challenge, the triumph of determination over adversity. This is where this slot last week. I hope the message is coming across. We heard from Damilola how she even had to step back from her normal day-to-day activities, abandoning a more lucrative to focus on a more lucrative living, to focus on this challenge that sickle cell is bringing to our life. Now we've had a mom's story. So what I want to point out is that we are capturing this as all will come out as a position statement. On the one hand, Damilola was keen to talk about resourcing. But we're here now. The lady has just been speaking about one of the key messages I picked here. I'm sure people pick out various angles that what sort of support, how to support her to keep her activities of daily living, in particular her job, going. Those are kind of things that begins the reality of what, when we are approaching those who make decisions in our community, they say, what is it? What help can we provide to people? So I'm teasing out this so that people should also begin to tease out when we come towards the position statement. Our next speaker is going to be, if I can navigate this, I think according to the program, if you bear with me, our next speaker is, we're now going to go to the patient groups across the globe. So we're going to start with Ireland. I think we had Laura earlier. I hope Laura is still on the line. Laura, are you there?
Yes, I am.
Okay, Laura Wogu. This when in the days when I used to be chief executive of Sickle Cell Society, it meant all the jobs of the WHO and various plus UN and all that. These are the foot soldiers that are the lieutenants, if I can call them that way. And Laura is still very much into it. Some of us have moved on into other areas, but Laura is still very much. This is something. So I without much ado, Laura is actually runs the Sickle Cell and Thalassemia Association in Ireland. And the best person, I'll leave it Laura herself to tell us. I don't know if there were any slides or there were any. I can't remember if there was any. Was anything sent over to the technical team, Laura?
No slides.
Excellent. So we've got 5 minutes, and Laura, you've got the microphone.
Thank you, Dr. Asa'ah, and thank you, everyone.
We're not seeing you.
Oh, sorry. And you mentioned it. Okay.
Yeah.
Apologies, the light goes off and on.
We can see, well, I can see you now. I hope others are.
Okay,
Wow.
Thank you.
Excellent.
Thanks, everyone. My name is Laura Wogu, and as you can see at the background, I have the European Sickle Cell Federation because I work with the organization as the Chief Operations Officer for that organization, but at the same time, founder and CEO of Sickle Cell and Thalassemia Ireland in Dublin. Now, I'm here today to talk about Ireland and what we have been doing so far. What are the challenges and what are the impacts or outcomes or positives that we have experienced over the last 12 years? We started the organization as a thought in 2010, and then we started working on research, putting together a team in 2011, officially registered as an organization under the Company Registration Office in 2012, and received our charitable status in 2013. So it's been growth year every year, and it has helped a lot because awareness now is massive in Ireland. A lot of patients are able to speak about their experiences, and a lot of families are now able to talk about what they're going through. Regardless, we still have the stigma. Just as the last speaker mentioned there, we do still have a lot of families experiencing stigma, and they don't want to talk about the situation they're going through, to the extent that the children are not aware that they have sickle cell. They just know they are sick and they go to hospital. And then as we work with the two hospitals, we work with the Children's Health Ireland, which caters for children with sickle cell. And also we work with the Adult Center, which is St. James Hospital in Dublin. Both of these expert teams, we work very closely with them. And in the midst of it, we work with the transitioning team on transferring patients from the Children's Hospital to the Adult Center. And you find that we have encountered a lot of youths that are falling through the cracks due to the fact that they are in a new field. And this new field, in this case, is that when they were children, the parents weren't talking to them about sickle cell, about their condition. They were making all the decisions for them. And now when they transfer to the Adult Center, and unfortunately, the system changes whereby the parents are not allowed to make decisions. The child is now the adult, so the child has to make decisions on treatments, on surgical procedures, on attending appointments, on being admitted, and they are really lost in this situation, in this scenario. They are lost in that they need that support, and it's as if they are just learning about the condition. that they've had since they were born. So it becomes really difficult here, and that's where the organization then comes in to support the youths in that process. Most of these youths are missing appointments because they are really confused. They're missing, they're not taking their medication. They don't know when to say no. They don't know when to ask questions. So that's what the organization is doing. That's on the part of supporting the families. When we move to the part of strategic planning and development, the organization has grown further in that we are now working with various government agents in terms of pushing sickle cell forward to a national platform. As the organization registers and works on becoming the national organization for sickle cell disease, just like cystic fibrosis or just like hemophilia, we are now working side by side with the HSC on a patient forum. We are working with the Department of Health on the National Committee for Newborn Screening, which I represent the public. And we put in an application for sickle cell disease to be added onto the screening program, the newborn blood spot screening program. We are hoping for good results. Unfortunately, I can't share what is going on at the moment, being that I'm on that committee for ethics and GDPR reasons. And also the fact that as an organization, we have ventured into research. Research is very much lacking in Ireland. Sickle cell disease is very new to Ireland. The knowledge is very poor. Clinical treatment is very poor. However, they are doing their best. So now we are venturing into research, and that's where the organization is now a partner with the Health Research Board, which is led by the government, the Department of Education, Environment and Research. And we hope to put out our first research project on stigma surrounding sickle cell disease and affecting the mental health of families. This project is really vital, and once we get the funding, we'll be able to move ahead. We've had 3 different universities share their interest in running that project. And as well as that, we have the European Sickle Cell Federation, which is actually registered in Ireland and holds the operations office in Ireland, but also the headquarters in Brussels. And working with them on this project is going to ensure that the research can be put at a European level. On another hand, we are very happy and excited about the 2 drugs that came out, oxybrita and crizanlizumab. Treatment in Ireland is that currently patients are only having hydroxyurea, or they are having the exchange treatment, or they are having the transfusion treatment. There is no other major treatments apart from the management as usual with other countries. But from the fact that as an organization, we were part of reviewing the medical or the scientific program on the Scientific Committee of the European Medicine Agency since 2016, we were able to review oxybrita and crizanlizumab years ago, and we were very excited to see those 2 drugs now officially brought out as treatments for sickle cell disease. However, they are not in Ireland yet officially, but however, we also have patients who can access them on a special request from the pharmaceutical companies and through their clinicians. We are currently working with the pharma companies and as well as with the government agencies to see these 2 medications brought into Ireland and added on to the treatment plans for various patients. There are some very good positives that are happening in Ireland in the fact that sickle cell is recognized now as a chronic illness deserving attention, especially that came out as COVID happened. And also the fact that through our campaign in 2014 with the government at the Health Committee, we were able to ask for sickle cell disease to be considered for free treatment on a medical card, and all patients with sickle cell disease receive free treatment and all their expenses are paid for apart from the over-counter drugs. So they can attend the clinic and don't have to pay. It's paid for by the government. At the same time, sickle cell patient or sickle cell disease is also identified as a disability, and families who have children with sickle cell disease can receive a payment from the government without having to look to keep working. They can work for 20 hours or 18.5 hours and still they get a weekly payment from the government to support them. So those are the benefits that we are seeing, but there is a lot of work that we need to do. And in partnership with all the various agencies like HIQA on ethics, because we represent on ethics, the Department of Health on newborn screening, the Irish Blood Transfusion on trying to campaign for people of African and Asian origin being allowed to donate blood, as currently it's a difficulty due to the malaria parasite. So the testing has come in and very soon we are starting our campaigns again for that. And also working with the Patient Forum to represent on various committees. So things are looking good, but there is still a lot of work to do. And working in partnership with the European Federation as well has helped a lot, because on a European level, we are also representing majorly. Thank you very much for having me. And I hope I didn't take up too much time. Thank you.
Thank you, Laura, as usual. So you just read out these things right from second nature. But in as much as really out of second nature, but a very serious issues we're talking about. And this is setting the platform for when I will come to make my talk, my own response later. That will begin to show some of the things that we're talking about, best practice in how to actually influence decision-making. A lot of those things we're coming across, it seems as if they're just happening, but there's a lot of work in the background that Laura and her team have actually been doing. So thank you, Laura, and we hope that you'll be available during the Q&A, which is getting to very soon. So let me now try and see if we can get hold of your other colleague in Ireland. Before I even go to that, I think people may take this for granted. Laura mentioned something about transition. Transition is one area which is absolutely vital, where that child, transition that period where the child migrates from being a child to an adult. That period is a very, very delicate period, which a lot of people may not have realized. That's some of the messages I thought we need to begin to see, some of the best practices that the beacon that are emerging from these various groups that are actually, as they are talking to us. I just thought I should raise that particular issue. So Laura, thank you. And we know you join us on the panel, so we'll be having you again shortly. Have we got Esther on this other group in Ireland? This is the Sickle Cell Society of Ireland. Esther, are you on?
Yes, I'm here.
Okay, dear. Can I just point out that for people who may not be aware, that this is the thing about when you become a warrior in this surrogate advocacy. I use the expression surrogate advocacy because these are people who are not just they're looking at essentially in the wider. They look at the advocacy from a wider perspective of social justice, and they're willing to sacrifice their own self. Here is somebody who is actually lying in bed unwell, but she's very keen to take this opportunity to actually get involved with what we want to talk about. So Esther, you've got the next 5 minutes, but we can't see you though, unless you're hiding, you don't want us to see you, but we can see your sign here as the sign of the Sickle Cell Society showing on the screen. So yes, please, Esther, you've got the next 5 minutes. There you go. Okay, dear.
Hello, everyone. Sorry, Dr. Asa'ah. You know, I'm really tired from the heavy medications I'm on currently. So pardon me if I'm almost sleeping off on everybody else. And Dr. Asa'ah, I don't know if you have the slide on.
I am Mr. Folobi, have you got them? I sent them earlier. Mr. Folobi, you're muted, so I can't hear you.
Okay, which slide is this, sir?
There, Dr. Yinka, this is Sickle Cell Society Ireland, as opposed to the Laura did not have any slides, so the only slides from Ireland, you should have them.
Okay. That's
they were sent through Dr. Oduwaiye.
Okay.
You still
There are
can't get
two
them.
slides. Yeah, there are two slides actually.
From Ireland, right?
It was not Ireland.
No, you should have Sickle Cell Society of Ireland. Okay.
I don't have it. Sorry.
No problem.
Dr. Oduwaiye, could you forward it to him, please? It is very important because her presentation is based on those slides.
I will send it. He has it. Maybe he's got it somewhere. I will send it now. It's ticked that you received it. Sorry. Yeah, it's there with you again, second time.
Okay, SCSI.
Yes.
That's it.
That's the second time.
Okay,
Yeah.
is in PDF. I was saying it as in PDF.
Will you be able
to?
Okay.
I'll project it.
Yeah, the second time. Yeah. Thank you.
Okay. Hold on. Okay.
Folks, sorry to keep people waiting, but as I say, the patience means that something serious is coming through. So just give us a couple of minutes or a couple of seconds, and we should be coming back to it.
Okay, so I'm going to share it now.
Okay.
Where is this?
Well, he's sharing. Sorry, guys, I'm actually not well. I had a surgery last week, so I'm only recovering. So I told Dr. Asa'ah it's because of him I had to be on this today. So while he's sharing it, just to quickly introduce myself, I knew I missed the introductory part of the segments by a few minutes. My name is Esther Pepulon-Olimemen. I'm the founder of Sickle Cell Society Ireland and quite also active across the globe on sickle cell and in Africa as well. And I also have my arm of Sickle Cell Awareness Initiative in Nigeria, where we in 2017 launched a primary care service for sickle cell in the southern part of Nigeria. So for this presentation, I'm going to be looking at some of the things we've done in Ireland and as an organization where we started from. So next slide, please. So the foundations of the society actually stem from personal experience. And I have two children with sickle cell, and one of the first cases in Ireland, I had come to Ireland at a time where sickle cell was relatively...
Could you try again?
Sorry, that was Siri.
It's a button.
I'd come to Ireland.
Go ahead.
Sorry? Yeah,
Go
I'd
ahead,
come
please.
to Ireland in a time where sickle cell was, you could nearly say, unknown, and presenting with, a case. For my two children, it wasn't until over a year or so that their diagnosis came by. So it was a thing where personally, I knew I had, a barrier to break in terms of sickle cell awareness. So I kind of took this as initially a personal mission to understand more what sickle cell was about and how we, respond to sickle cell, and to personally, from that point on, personally educate the nurses at the time. I'm talking about 22 or 23 years ago in Ireland, where people had no healthcare professionals, had no knowledge of sickle cell. So it was a thing for me that I knew, just talking about it verbally wasn't going to make a change. How will I bring in a change? Is taking it a step further. So I went on, re-educated myself, qualified as a professionally qualified social worker, and I did a thesis that was the first research for sickle cell at the time, psychosocial research for sickle cell. And it was a groundbreaking study, not just only in Ireland, but across Europe. And the study identified a lot of issues and support needs that needed response for sickle cell families in Ireland. And that's created the families that participated in that study between 2006 and 2008 formed the foundation of the society, because they came together as the initial support group. And then again, we started meeting out in clinics while we waited to see, the doctors. And this was how we started sickle cell. So there were a lot of issues. And at the time, the influx of migrants, the rise in birth rates in maternity hospitals, there were growing cases of sickle cell, there was culture shock, the push factor. There were a lot of things that were challenges for us and things we had to deal with to get to the point where we went. So this was how we started. And sorry, the next slide, please. And somewhere along the line, Dr. Asa'ah, of course, became, instrumental to the early stages of the formation of Sickle Cell Society, because he actually, was the one that trained our board. And the first funding that was provided for sickle cell went to the society at the time. And this was the funds that were used to develop the board of directors for the society. So if you get to this slide, okay, that's the title. Sorry, I know I'm just talking. You can be moving the slides as you go. That's the title of the study. So what do we do? Number 5, please. So we offer patient, parents, and carer support advice. We provide referrals, education and training, awareness raising, research. We have a youth arm of the project, and we also have international and global partners as well. If we go to slide 7, so our key projects, the society has the Health Promotion and Public Awareness Project. This is where we do our annual sickle cell conference, where we raise awareness for sickle cell, and the World Sickle Cell Day event, which is a very big aspect of our sickle cell awareness in Ireland. And we have the Communities Outreach Project that also happens during September to November for Sickle Cell Awareness Month. So we take those 3 months and we go across the various counties in Ireland to nationally raise awareness for sickle cell. So if you move on, you will see some of the pictures of some of our activities. And we move to the next objective of the society, which is the Family Support Initiative. So here we work directly with the hospitals in Ireland, and we provide direct support for families. And we also carry out awareness sessions, and we offer practical support, as in when families are, for instance, in hospital and require, because most times when our children run into emergencies and they do not have, and the family do not have time to get ready. The child can be in school and the mother is called out that the child is sick, and the mother goes straight to the hospital. We are readily available to support that family, to bring in what they need, their basic needs, to the hospital for them. And apart from that, as you can see on that picture, we have the Easter project, for instance. Some children don't have the opportunity to spend their rituals at home. This is from a very personal experience where I would have spent, Easter, Christmas, and all the ritual seasons in hospital, and understanding the impact for families that do not have that liberty to be at home or in the community, that this initiative was developed. So we started going out to families during this, periods to support them. And we move on to the youth initiative. So to raise awareness for sickle cell, we have our young people's group. And again, this is something, that is so passionate to us, because we have young people, children that grow up, and even the broader community. If you look at that picture there, you see it's beyond just Black children that are there. You know, we try to raise awareness by using sports, using fashion show, using, you know, various strategies so that the awareness of sickle cell goes beyond just our, you know, own families or our own ethnic minority communities, and it begins to be acceptable within the broader Irish, you know, society. So football and fashion show for us are key aspects of our awareness raising strategy for our youth project. And apart from that one, supporting the young people, there are a lot of issues coming up, particularly as they transition from being children to adults, you know, issues around relationship and, you know, a lot of issues around, you know, even beginning to understand what sickle cell is for them, things they never knew growing up and they had nobody to speak to. So we begin to open up those safe spaces to talk to our young people about sickle cell. So if you go ahead, and our young people are very active in also, you know, raising funds for sickle cell. So in 2015, they mobilized and raised over 5,000 euros for the Sickle Cell Research Center in Children's Health Ireland. And this was out of a campaign, Sickle Cell Matters, hashtag Sickle Cell Matters, that, you know, the young people came up with. And this was a time where my daughter Reme was so sick and she was almost dying. So we needed to, you know, raise awareness for improved care support and education for sickle cell in Ireland. So if we move ahead, those are our key campaigns. The other one was launched in 2015, and the newborn screening campaign was launched in 2020. This was following previous presentation in the Parliament for newborn screening. So if you move ahead to slide 14, it still gives you an indication of our other objective, which is Partnership and Public Policy Initiative. In this objective, part of what we do is representation at the Oireachtas. Oireachtas is, you know, our own House of Parliament. And we also partner with Irish universities and colleges and key health institutions and professionals and leading advocacy organizations to raise awareness. So whether locally or internationally, we also have partner Professor Simon. He's retired now. We partnered with his university, which is still ongoing in De Montfort University, and with, you know, other institutions in Ireland, the major hospitals in Ireland and the blood transfusion units and the Department of Health. As we move further, you see that. So one of our major partnerships so far that has yielded quite positive impact in terms of, you know, raising awareness for sickle cell within our medical institution is our partnership with Irish universities. And this is where we managed to get sickle cell into the Irish university curriculum since 2013 to date. We have been giving special lectures and symposia on sickle cell. And each year we offer lectures to approximately over 800 training medical doctors to date. And if we look at the impact of that, like I work in healthcare, and you can imagine somebody I gave lecture to in 2015. I've walked, you know, I've walked along the corridors of my hospital and I've met some of the doctors. They are now practicing. They walk up to me. They're like, "Oh, I remember you from that lecture in Royal College of Surgeons in Ireland," you know. And for me, like, this is it. Like, I remember when I first came to Ireland, looking back, you know, 22 years ago, people didn't know what sickle cell was. But today we're proud to say, you know, we've been able to get sickle cell to that point where the universities can recognize and they feel the need for sickle cell to be part of what. So we laid that foundation and opened that doors for that level of acceptance to be there in Irish universities. So also, as part of our partnership and public policy initiatives, we COVID was a very significant period for families. At this point, we were part of the committee that negotiated for sickle cell to be given priority in Ireland during, the emergence of COVID, and became part of the HSC COVID-19 vaccination committee. We had a partnership project with the Department of Rural and Community Development. In that project, we had various activities to support families while they were going through COVID. We had some of the activities carried out were like online support groups. We had tele-support, we had practical support where some families required practical help in collecting prescriptions. These were done under strict COVID-19 precautionary measures at the time. You needed like a particular pass, granted by the Department of Rural Community for you to be able to do those activities. So, our volunteers were, to be honest, I really would like to use this platform to appreciate them for, stepping out in those very difficult times to support our sickle cell community. So we also had education and awareness events online that was ongoing, and some seminar and training workshop. And of course, we still had the safe space for our young people who were the most vulnerable during the COVID period. So that's project, that's the cover you're seeing there is the reports, the final reports of that partnership project at that point in time. So still based on our partnership and public policy initiative, this is a presentation under a joint campaign by ourselves, Cystic Fibrosis Ireland, Irish Medical Council, a number of organizations coming together in 2014 when we did a joint presentation at the Irish Parliament Health Committee. And newborn screening was one of the things put forward specifically at that point in time. Just not to waste your time, I talked about Dr. Asa'ah. I had to have this picture on this, just to give him some good memories when he, came in for our board development and some of the very, interesting ideas that he put forward at the time. And before I forget, we also are a huge part of some of the decisions that affect some of our families. I know that we talk about our families living in the community. We also have our families that live in direct provision. I don't know what you call that in the UK. In Ireland, this is a service for people seeking asylum, and they are looking for refuge in Ireland. So some of our families live in direct provision. So we're also instrumental to the policy development that transformed the current position for people living in direct provision. We were part of the writing, the drafting of the white paper, and several meetings with the Department of Children, Equality and Disability at the time. And we're hoping, that even as the white paper had been passed, that everything will become effective for people living in direct provision. So this is not a situation where it's only sickle cell families, but because we know our families also represent a percentage of people living in direct provision, that we became part of that process through some of the, joint advocacy work we do with some of our partners. And we had that opportunity to sit in that committee and walk through that process to support, families of people with sickle cell in such accommodation, so they have better accommodation. As we know, having sickle cell is one thing, then your lifestyle, your housing needs, your access to basic needs can impact how, your health improves, or, how the crisis escalates. And direct provision is a system that, we have advocated for change in. So just to move forward, to also acknowledge the progress we have made in newborn screening and some of the personal meetings I had in the last 2 years with the minister. We put in proposal as a group, as an organization to the minister, positioning, ourselves in terms of some of our children that have suffered, the extreme impact of sickle cell and the need to consider, children that are yet to be born, not to go through the same things our children have gone through. So like I said, this was a personal journey for me. It started as a personal journey that has become, what it is today. And if you go through the next few slides, you would see some of the pictures, if you want, of, an experience I've had with my daughter with sickle cell. Like I said, I have 2 children with sickle cell, and it's a life story for me. Those pictures speak. Like, I can't say much of, in words, what I've experienced with sickle cell. Like some of the doctors spoke here earlier on, they talked about some of the impact of sickle cell crisis and all of that. The pictures you're seeing there clearly speaks of some of the extreme impacts of sickle cell for children. But today I can tell you, because of, a lot of advocacy and joint and collaboration from international partners, this child you're seeing here today is doing very well and is still alive, despite I heard 1 million times she could die. So that is the importance of the conversation we're having here today, how we can improve lives, we can change the narrative for our children, for our families, for our communities. How do we go about this? No other way other than collaboration, other than learning from what, people have done or what they have done differently, and, making a decision how to go about what we intend to do. Thank you very much for the opportunity, and God bless. Thank you.
There you go. This is a fantastic sort of thing that makes one really uplift. This is a lady who was actually lying, but seriously unwell. But again, like I said, when you get involved in social justice advocacy, surrogate advocacy, it's almost like some sort of a drug. You get, it comes. Look at somebody who's lying there seriously unwell. People may not know this. When I spoke to Esther yesterday, I wasn't sure that she would be able to speak today, but there you are. The moment she gets into the auto mode, is something else. I just want to say something that you see, hopefully this is what is going to come out of this for those organizations in Africa that we're also trying to bring them into the frame. There is this thing about you give an organization roots and you give them wings and then they fly. Esther mentioned the early days, the days when we were looking at essentially how to develop a board in Ireland. I remember one issue, but I don't remember this one evening, we had just about 2 hours for me to explain the concept of the planning triangle. Because like I said, sickle is an opportunity for us as Black people, minority ethnic people, to show that we can also run something to world class. Here in Europe or in America, to get funding is not easy. You have to compete with other white organizations. And to compete with them before you start talking about equity, which is the title of this thing, equity in the whole thing about advocacy. You have to show that professionalism. I explained the concept of when Esther mentioned about the board, it was essentially try and give some sort of a background on the planning triangle. But the next day, my goodness, we were in front of the health executive of Ireland. I couldn't believe how this lady, how much is, I was more learning the planning triangle from her. Anyway, just to say that this is some of the we'll also see how we can share that. The benchmark, we've spoken about Ireland, Laura and Esther have spoken. Now let's look at another gentleman who is doing some fantastic work in Uganda. A few years ago, I was chanced by the Global Blood Fund, another organization will bring into this project, by the way. The Global Blood Fund suggested that we go to Uganda within the framework of research network on sickle cell disease. We met a young man who was talking about the cold chain the cold chain as to how they could also ensure that there is adequate and safe blood supply away from Kampala. And that's how I met Ashraf. And of course, Ashraf, those who are on the social media on Sickle Cell Matters will know that this is someone who is so, and I was so, first of all, shocked by how young the man is, and then what he has actually achieved. So please, Ashraf, are you online?
Yes, I'm on.
Excellent. So I'm going to let Ashraf speak for the next 5 minutes about his initiative, just like I'm sure people will be spellbound, like we heard from all the other speakers so far. But again, let's look at what is happening in Uganda and perhaps beyond. Ashraf, you've got the microphone.
I hope my slides are on.
Yes, Mr. There we go.
Good afternoon, good evening, and good morning from wherever you are. My name is Sebandeke Ashraf. I'm the co-founder and executive director of Action Against Sickle Cell Disease. We are an advocacy organization and also a support group. So our vision is to see that we have a world without sickle cell. And one of the things that we do, we have called it SPEARS. SPEARS, we are looking at sickle cell prevention, policies, education, awareness, research, and support. Those are the things that we are looking at to see that we can realize our vision and our mission. So our organization works basically in Eastern Uganda and Central Uganda. Can you have the next slide? Okay, this is the status of Uganda. In Uganda, 13.3% of the population are carriers of the sickle cell. So that's a very, very, very big number of the population. And 0.7% are living with the disease. So meaning we have a very, very part of the population that are afflicted and affected by the disease. And in this, that's why we came up. So as you can see the map, where you see the dark part is where the prevalence of the disease are high. So like we said, 13.3 of the population, but in some districts we have as much as 20% of the population in the district who are carriers of the gene. So as an organization, we decided to do something about this because we couldn't just sit and look on. So one of the things we have done, because most of these people are in the rural areas, so we moved to the rural areas and we decided to have intervention to bring care and support. So one of the things that we have done is the start of the sickle cell clinics. So these clinics bring the services closer to the people. So we have the treatment, we have the education, and it doesn't matter where we are. So as you can see from our slide, one of the clinics is run under the tree. So it doesn't matter whether we have the shade of the tree, as long as we can get the drugs. So far, we have 4 clinics in the eastern part of Uganda and 1 clinic in the central Uganda. So these clinics see more than, we have a membership of more than 2,000 patients who are receiving free services from these clinics. So they can receive, they get the treatment, they get the testings that are affordable. They get in all of these clinics, we are able to do the testing. So we initially some of these people had to move more than 300 kilometers to access these services. So meaning those who couldn't afford, they were staying home, or they were going to places where they are not getting the services they needed. And next slide. So another thing that we are doing is community outreaches. So we take the services to the people, because initially some people, if you needed the services, you had to travel like to the capital, Kampala. If you need to know your status, or if you need to get the education about sickle cell. But what we have done is we take the services closer to the people. So in this, we educate the population about the disease, because as our vision is to have, we want to have a sickle cell free generation. So you can't have that when people don't know their status. So we do these free services because if you are to do this test in a lab, it can cost you more than $10 to take the test. And you find that most of the people who are in high burden areas, they live on less than $1 a day. So you can't go take a test when you haven't gotten something to eat. So we do the outreaches. In these outreaches, we do the screening. So far, we have screened over 7,000 people, and our education outreaches have reached more than 20,000 people. And currently, we even work with the Parliament of Uganda at its annual Parliament Health Week. So where we sensitize the members of Parliament about the disease, and we also do the screening for the members of Parliament and the general public. So in this, we want to not only to have them know, but we also shape the legislation. Then another activity that we do for the community is a project we call Feed a Warrior. Feed a Warrior is a nutrition program. It's not a feeding program, it's a nutrition program where we teach the community how best they can use their small gardens to grow nutritious food. We also do nutrition counseling, we do nutrition education, and we do food demonstration, because we realize that some of these people might have the food, but in the process of preparing it, it loses the nutrients. And someone take feed on the food that doesn't have the nutrients. So we do the education, and we teach them to make porridges that are nutritious using the materials available in the communities. So another program that we do is called L Committee. Next slide. It's L Committee. L Committee is like a community health insurance. So in Uganda, at public health facilities, the services are free. But sometimes you realize that you get to a point where there are drug stockouts, where you need to go to be referred to a higher facility, and you don't have the money. So what we decided is what we piloted the program at one of our sickle cell clinic in Katakwi. And initially, our initial idea was for each time these members come to the clinic, they pay 1,000 Ugandan shillings. So that's where even the name is L Committee. But when we engaged the people, they told us no. According to the benefits of the program, we are not even going to pay 1,000. Can't we pay 2,000 every time we come to visit? And this money that they put together as group has helped. Like in case last year, we had a situation where the hospital had stock out for the essential drugs for 6 months. And in this 6 months, these patients were getting the drugs because the savings we are hoping to purchase the drugs in bulk and be given out. And also in cases where we have patients who are referred to higher facilities, normally the hospital has the ambulance, but at times it doesn't have the fuel. So they can tell you fuel the ambulance, and you'll be able to be taken to the hospital. And sometimes this happens when you don't even have the money. So what we have done is when such emergencies happen, we just get the money that has been saved and fuel the ambulance and taken, so that we can save their lives. So all this has happened without challenges. Next slide. So one of the challenges that we have faced is limited resources. So we have the very, 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 very big numbers that need our services, but we don't have the resources are limited, and we are being called everywhere in Uganda. You come and do this that you have done there, but we are limited. Another challenge that we are facing is data, because as we talk about these percentages, like 0.7% of the population have the disease, but we don't have the data. We don't put the heads to these statistics. So we don't have reliable data to know where people are and who are they. So that's a challenge, and we have tried to get this data, but it's quite expensive because you need a team to do this. Then another thing that we have faced is we have a mismatch between the passion and professionalism. Where we work, we have started chapters. For example, we say Action Against Sickle Cell Disease, Katakwi chapter. So we have people who come to form these teams. They have the passion, but they don't have the management qualifications. So you may have a few and then the others. So that delays our work, and we don't move at a pace that we would have wanted to move on. Then in Uganda, sickle cell ranks lowest on the priority list. So that means our work is delayed because we want to achieve, for example, we need to have legislations, but when you go to parliament, they tell you, okay, there are some other things that are on the list, you can wait. You go to local councils, they tell you, okay, sickle cell is not so much of things we are looking at. So that affects our work. Next slide. So the way forward that we are looking at to better our work and to serve more people, because we have so many people that we haven't served and we want to serve them, because we have so many people that haven't reached a sickle cell clinic because the clinic is so far and they can't be able. So one of the things we are looking at is trainings and capacity building. That's for the people we are working with, and also for the medical officers, because most of the medical officers we interact with, they don't know best how to manage the sickle cell patients. And then another thing that we want is to have a national sickle cell register, so which we hope it can be able to help us know who is where and who needs the services and exactly what numbers do we have. Because some of the clinics I've talked about, some of the clinics have similar patients. So you go to this clinic, the patient has been to like 3 sickle cell clinics, and each of these clinics are counting that as a statistic. So we also work towards have a national sickle cell register where every person diagnosed is entered into that register, and you can know who is where and who and where are they and who are they. Then we also looking for more resources to do our work, because the burden is high, but the support is still low. Thank you very much.
Thank you, Ashraf. As usual, another excellent delivery, which didn't surprise me anywhere. I can see here some of the way you've actually highlighted the challenges, which makes it very useful. Again, the salient message of the triumph of determination over adversity is actually coming across, and of course in a more organized way, which is what we want to do, so that we can pull together at the end of this a clear professional position statement. So thank you very much, and I know that you're going to hang around when we come to Q and question and answers. We should now move on to, I think Mr. Asa'ah is actually online. Mr. Asa'ah, are you online from Cameroon?
Yes, I'm online. I hope you can hear me.
Yes, I can hear you, but I hope Mr. Afolabi, can you hear Mr. Asa'ah from Cameroon?
Can you hear me now?
Mr. Afolabi, can you hear?
Very well, sir.
Excellent. So I assume that it's going across. Dr. Oduwaiye and the team at the conference center, can you hear him?
Yes, sir. I'm Ashuegbe from Douala.
Yeah, I just want to make sure that the people at the conference center can follow. So can you follow it from the conference center in London? I'm actually talking for being my name. I'm actually here in Edinburgh, and then there's a team in London, and then we're all over the globe. So this is the wonders of what
we're hearing you, but we're not hearing.
Excellent. So Ashu is doing some fantastic work in Cameroon, and I'll leave like I say, this thing is something like second nature when you get any of these advocates, these surrogate advocates, and then it's best to listen to them, but don't take it. It might seem as if it's second nature, but they're giving us some very serious messages. So, Mr. Oduwaiye, you've got the microphone from Cameroon.
Yeah, thank you very much, Dr. Asa'ah, for having me on this webinar. My name is Ashuegbe. I'm a 56 years old sickle cell warrior. So I've been living with sickle cell for 56 years. I usually use on my social media handles, I use hashtag 56+ sickle cell warrior. I've been living with sickle cell. I started advocating for sickle cell about some 35 years ago. That was in the UK, in Birmingham, precisely when I was part of an organization, Campaign Awareness for Sickle Cell CAST. So when I came to Cameroon, I continued with CAST Cameroon, and we have been working as in the area of sickle cell awareness and management. Until last year, I actually had to take an early retirement to, because of stress with the area of work that I was doing, to focus now on sickle cell awareness. So I won't prepare the slide we have on the screen. We know about sickle cell, what it is. And according to the statistics in Cameroon Ministry of Public Health, there are about 6,000 babies of sickle cell babies born each year in Cameroon. They also say that we have 22% of the population who are carriers of the sickle cell gene. That is the average. And most often people who are carrying the sickle cell gene, that is AS, are the ones that will end up having babies because they are in good health. Two people who are in good health, when they come together, they have a child who has sickle cell. And this is usually because they did not know, they were not informed. Some couples even usually during the first 2 years, because they don't even know that the child they have has sickle cell, they always usually have problems. Next slide, please. So in the area of sickle cell, we're focused in two areas: sickle cell management and sickle cell awareness. Like the case of Uganda and many other people have talked, I would believe that, when sickle cell patients have routine follow-up, they can reduce the frequency of hospitalization due to crisis. So what we are doing at our organizations is we're in partnership with some hospitals where we run what we refer to as sickle cell clinics, like the case of Uganda. And once every month, sickle cell patients worldwide go to the hospital for their routine checkup. During this visit, in addition to meeting other warriors and sharing health talks, they go to the labs for the control of the HB, and after that they have a one-on-one with the doctor. If an issue is diagnosed, if there's an issue, it can be early diagnosed, and actually some plan of action, put in place. So usually they go home at the end of the day with medications, folic acid, painkillers, that is provided by the foundation through, of course, our supporters and sympathizers who have been the ones contributing for this. So in the long run, at the moment, we have 3 sickle cell clinics, 3 hospitals that are hosting sickle cell clinics. And the long run is to have other, partnership with some other hospitals to operate sickle cell clinic, because we believe that sickle cell clinics are very important. Like I just said, the routine follow-up can reduce the frequency of hospitalization due to crisis. Next slide, please. So yeah, we'll see some of the images that were, during the sickle cell clinic sessions. Just this morning, we have one of the sickle cell clinics in our capital city in Douala, an economic city in Douala. This morning, we were together with the sickle cell parents. Interestingly, it's mostly the mothers that bring the children to the sickle cell clinic. So it's only and some of them, as well, people might know, have some mothers are single parents because the fathers have left them because of the sickle cell children. So yeah, we have the sickle cell clinic session, you have the testing for the HB, and after that you have one-on-one with the doctor. The next slide, please. So the second area of our focus is on sickle cell awareness. I talked earlier about the statistics in Cameroon, 22% of Cameroonians being sickle cell carriers, but most of them, more than 80%, are not aware that they are sickle cell carriers. So we initiated what we call the Operation Know Your Genotype. And here we are targeting the youth from maybe 18 who are just starting their relationship. We are saying youth from that area who are just starting, because just yesterday, for instance, I have a nephew who came to present the fiancé to me, and they are already into, final stage of their relation, marriage. Then they realize that they are all AS. So they are really, really in a serious problem. So that's why we're targeting the youth, so that when they start a relationship, they can start already talking about their genotype, their status. So the plan we have been doing is we go to the rural areas, to institutions with many youth, like churches, higher institutions of learning, and do what we call rapid sickle cell testing. Because in the lab, the normal lab, if you were to send people, we tried it once, ask people to go to the lab at a reduced rate. In a month, you will not have up to 5 people. So now the plan is we move to the community and get this test done. And you can, in a day, you can do like between 50 and 75, 100. So we have been going to these institutions, and it is very interesting because there people do it. And at times we are targeting even elites who can sponsor this project, Operation Know Your Genotype, in their communities for free, and certainly have many more people join. Our goal is to lobby, and we have started already, lobby the government which is not very, hasn't really put sickle cell as a priority. So it's to go to the government through the legislators to pass a law, like it's in some parts of Cameroon, some parts of Africa, sorry, like I think Nigeria has that, a law that would be making it obligatory for people to know their genotype before marriage. We started this early this year, and we had a meeting with one of the government ministers. We're hoping to continue. It may be a long process, but we believe that in the long run will be better, because this number of the 22% of carriers that we have, if more people are informed and educated about sickle cell, that this percentage can get down to less than 10 even in the next 10 years. It's a long process. We are in it. Like I said, I'm 56 years old, almost 35 years in advocacy, and we'll continue to do this for the sake of, advocacy and making sure that people know what sickle cell is all about. The stigmatization is less now. People are beginning to come out from the small corners and joining for support group, because it's very, very important to be part of a support group. The next slide, please. So it's still like I said, we hope we are using elites to support the Operation Know Your Genotype in their communities. And because in Africa, because of the hardship, at times it's very difficult for people to spare, even if it's $2 to do a test, which is good for them, health test. But whereas if they provide it, somebody provides it for free, pays for it, most of the youth will do it. We believe that to take the message to the nooks and crannies of the country. We need volunteers, we need to serve as advocates. And so we're working with volunteers, we're training them because they need to, before they go out into the community to talk about sickle cell, they should be trained, they should know what sickle cell is about, they should be ready to answer the questions that will be fired to them. We have the media. The media is very important. We have been using them by using the media and the celebrities to help in this sensitization campaign. And the next slide is actually images of what we do during the sickle cell awareness. It's rapid sickle cell testing, training of volunteers and advocacy, involving celebrities in the advocacy, and the use of the media, very important. Like the Uganda case, of course, the challenges, at the first presentation that I had a slide with the challenges at the end. I probably removed it, but they're very similar. The same limited resources. Like I said earlier, the government has low priority on sickle cell, whereas you have a 22% of the population are carriers, which is supposed to be high public health priority. So we continue to talk to the population, even get people who are keeping their children, because especially you won't believe that most of the time is some elites who don't want to be tagged as having children who have sickle cell, that keep their children in their houses. So is to bring all of these people out. Then those who don't even have the means, like the sickle cell clinic that we run, some were encouraging them that you should not, your status, financial status should not deter you, should not keep you away from the clinic. Come and the little we have, we share, we support you, do a hemoglobin test. Once you do that regular every month, and maybe every quarter or every 6 months, you do the full complete blood count test. You have a doctor who is regularly following up. The chances are, and you are taking good care of yourself, you are avoiding the things that you are not supposed to do. You can stay away from crisis. Like myself, I've not been in crisis for about 2 years. I've not had a crisis. Of course, I have the occasional mild pains, but not being hospitalized for more than 2 years. We can manage sickle cell. We can get people to live with sickle cell. I'm 56 years old. I have friends, I know people, unfortunately, they are not ready to come out, who are 60 years old and above, but they probably don't want to. It's a personal decision they've taken not to talk about it. We stand to, when I talk about it, I give hope. I give hope to parents who have children, that it's those children who can grow to be professional, because I'm an engineer, a civil engineer. I've worked in the oil and gas sector in Cameroon. So you can be a professional. We can do whatever it takes. The other day I was saying that I could this day die of something else and not necessarily sickle cell. I can be crossing the road and have an accident. I can die of something better. So we have to live our life to the fullest and know that sickle cell is a challenge, but we can go beyond that challenge if we have a positive mental attitude towards that. Thank you very much.
Dr. Asa'ah, we cannot hear you.
Dr. Asa'ah, good.
Okay, can you hear me?
Yes.
Okay.
Yes.
I just wanted to make sure that Marie Claire is on the line. Marie Claire, are you on the line? No. Okay. Thank you, Ashwegbe. I think, again, the way we organize this webinar was to bring in this sort of clarity, evidence, clear cases, case studies, where the determination over advocacy. I keep saying this over and determination over adversity. I've said it so many times, but I couldn't say it enough. We have actually captured here the realities by sampling a number of countries across the world. There could be many more, but we haven't got that much time. We could go on forever. But I think the message is emerging, and we have been capturing this behind the scenes so that we're going to come up with a position statement. That position statement will be circulated to all the stakeholders who have actually taken part today, so that once, hopefully, that should be something that will going to be an empowerment tool for us, so that if, when in the next time we have another meeting, we want to hear that, perhaps people will say, as a result of this, we achieved that. As a result of this conference today, we did achieve that. That's what we want to do, so that it shouldn't be just another talking shop. We've heard from the medical doctors. We've heard from an array of personal stories, as well as family challenges and patient groups. Perhaps I would like to invite the team from Great Ormond Street. Great Ormond Street is a hospital for sick children in London. And they have some very interesting ideas that they would like to see how we can actually engage those of you who have actually the stakeholders in this project, in this conference today. So Ade, are you online?
I'm here. I'm here.
Okay. So Ade, yeah, I'll let you to introduce yourself and then introduce your project. I want to assume that Dr. Lola Oni is also.
She's around.
Okay,
yes,
so
I'm also here, Asa.
Excellent, Lola. I know troubling my people on their holiday. Lola is supposed to be somewhere with the family in the Mediterranean.
I'm in Malta at the moment.
There you go. but as you say, you can move away from UK, but you cannot run away from Asa'ah. So there you go. Ade, you've got a microphone, please, from the Great Ormond Street Hospital for Sick Children.
Much appreciated. Thank you very much. And a very big thanks to you to have invited me to this very wonderful forum. I'm here in company of my other colleague, Dr. Lola Oni, but I'll just give a quick insight into what brought me to this space today. I run the largest screening laboratory in the UK, so at the Great Ormond Street Hospital. So we test for every 1 in 5 babies in the UK born in this country. I also have my background is biochemistry. So I studied in Nigeria and I've come over to this country and spent my last 3 decades in the pathology labs doing all sorts of things. And of course, I also am a deputy chief of service for the organization. But what actually has brought this to light for me is we've spent years, in fact, decades, trying to bring ourselves to a place where we can actually start joining up ideas. And it's so great to see. I kind of marvel at all the stories I've heard today, as well as all the initiatives that are happening across the globe. One of the things that is still kind of bothering the mind is how far we haven't traveled, how far we could have gone, and perhaps why are we still being held back. And I think this is where we want to draw some kind of mission statements as to what we can do in this space. We've got people with full knowledge of what happens to people with sickle cell. We also have people that have the expertise and the knowledge to take us to the next level. So I'm here presenting a project which was born out of just wanting to make a difference. And at the Great Ormond Street Hospital, which is the well-known children's hospital in the UK, we know for a fact that we can offer some things on our digital platforms. So I look at the digital platforms we have currently and we think lots of things you've shared today, a lot of stories around education, stories about patient advocacy, stories about how we can ensure care is kept in the home rather than having to go to the hospital all the time. We've heard stories about clinics that actually are set up even under trees. I think it's kind of very powerful to hear the story of, I feel very humbled. And I think this project we're proposing is going to be co-designed with yourselves. We feel we have to be in a place where we're bringing together your ideas into our space and using our own engines to drive the solutions. So I'm just going to leave it as that for now, because I think it's quite important that I let you engage in the best possible way. I'm going to share this space with my sister here, Dr. Lola Oni, who I think should be able to pitch something about what the initiative is about as well. Over to you, Dr. Lola Oni.
Thanks very much, Ade. I think Ade has a very good evening to everybody. We're about, I think, an hour's difference here in Malta. I can't really show off with the fact that, it's nice and hot here, but, because it's hot in a lot of places where you all are. But I just wanted to add to what Ade has said, that, this initiative, the whole objective why I agreed to participate in this is the opportunity to provide collaboratively, to provide some support for education and some support for capacity building, because quite a number of people have mentioned capacity building in their lecture. And I think this is an opportunity because I know I've been in this field now for, almost 40 years. And the issue that a lot of my colleagues, particularly those in Africa, always talk about is the lack of access to educational materials, lack of access to opportunities for education, as well as clinical, clinical learning. So I think that's why I'm very interested in this particular project and have given it my backing. We want to be able to enable people to access good quality information and material, because we're now very much a global community. So there shouldn't be anyone who's not able to access information or education. So whatever small way we can help to produce some of those materials with the support of our colleagues both in the diaspora as well as in the host countries, that is the objective. And I'm really looking forward to working with everyone that agrees to support this project and want to buy into the idea of the global learning that we hope to do with this Great Ormond Street project. I want to say thanks very much to Dr. Asa'ah for giving us this opportunity to say a few words, because I know we're not part of the program, but he allowed us to at least come and tell you a little bit about the project. And I'm sure if you want to know a bit more, we'll be quite happy if you contact Dr. Asa'ah, we'll be quite happy to send you a little bit more information. Thanks very much, Asa'ah.
Yes, thank you, Lola. As well, people maybe people may not understand why we had to rope Lola into this. Lola is the immediate past director of the Brent Sickle Cell and Thalassemia, not only center, but actually within the hospital, all the community engagement works in Brent in the Northwest London. And when I moved into the advocacy of sickle cell, this is going back about 20 odd years, they were the ones that I actually learned a lot from. I got into sickle cell issues because of a personal experience. As people may not know, I lost my own son, my first child, to sickle cell disease in 2002. At the time, I was an expert in nuclear medicine, but then just like Esther's story, somebody had to do so. I'm just like all of us, really. Personal experience, then you say you have to do something. But I went into that sector, I had no clue what it was. Luckily, I was taken I was put on secondment at the Sickle Cell Society, which was attached to Lola's unit, and I learned a lot from them. So even though I said, as Lola is a nurse, doctor, lecturer, and immediate past director of the center, and of course, when Ade's project came up, we said, here is an opportunity to do things differently. Do things differently in the sense that we don't want a conference like this to just say talking, and then people say, well, we are sick and tired of us, the patients who come and talk, then nothing happens. Here is an opportunity. And I know that we have other people as stakeholders also online today. I know my friends, I don't want to start putting them on the spot, but I know I can see them on the attendance list, that we're going to rope them after this to make sure that we can ensure that when we meet again in a few months' time or next year, people who want the service user to say that after their cry, something positive came out of this. So they've already given us a lot of positive news in terms of what they've achieved through their own determination. But now it's time for us. So Lola, thank you so much, you and Ade. And we know that we're going to make maximum use of the opportunity that you're actually giving us. Thank you very much. And Lola, enjoy your break in sunny Malta.
Thank you, Asa'ah.
Okay, so that's where we come now to, so continuing the response, Mr. Folabi, could you put on my slides, please? If you go to, yes, part 2. Thank you so much. I hope the folks in London, can you see the slides? Dr. Oduwaiye, can you see the slides? Can you see the screen? Okay. The people...
Yes, we can see it.
Okay, wonderful.
We can.
Yeah.
Hello, hello, Dr. Asa'ah.
Yes, dear.
How are you doing? Sickle
I'm okay. Who am I speaking to? Who am I talking to?
Savannah from Sickle Plus.
Oh, yes, Sickle Plus. My goodness, all my lieutenants are on the line today. Thank you. Wonderful. Anyway, let's look at how we can actually be. I want to just put a brief framework, and then we go into question and answers. Now, I want to start also by again thanking Dr. Ayoka Oduwaiye with the Sarah Ayoka Oduwaiye Foundation, because this is an opportunity which I want, in as much as, like I said, I've moved on from a lot of sickle cell things, because my focus now, for obvious reasons, for those who live in the UK, is how to free up hospital beds. So freeing up hospital beds, I've been doing that for the past couple of years. When I left Sickle, I went into hospital inspection and all that. But I took to this one because I continue to, we all, like we've heard, we continue to receive challenges, message of challenges that our warriors are facing across the globe. And I saw something different in this approach of the Sarah Ayoka Foundation. I saw something different in the sense that it's an opportunity for us to address things from the usual, away from the usual, come to conference, speak, and then people go and make a lot of statements, and then patients get the meeting somewhere and they're all frustrated. Dr. Asa'ah, nothing happened. Now, I've always said that sickle cell is a medical challenge, but it is also something to prove that we, as people of the Black and minority ethnic community, can run surrogate advocacy to world-class standard. I say this because I take the benchmark being the flip side, where you have sickle cell. The flip side tends to be, I'll talk about cystic fibrosis. I'm not going to give a lecture on cystic fibrosis, but I'm saying that sickle, just like you have the sickle in the Black minority ethnic community, you have cystic fibrosis. But if we look at what these two challenges have actually delivered in terms of influencing the mainstream agenda worldwide, you will be talking about chalk and cheese. So having said that, the green shoots are there. The green shoots, we had the green shoots from Ireland. We heard what those two ladies are actually delivering. We also heard some of what people are doing in Africa. The organizations that were given the opportunity to speak today were not just taken at random. We will consider the fact that they are actually benchmark that can actually be used for in terms of building up to the next level. We heard from Cameroon, we heard from Nigeria, we heard from Uganda. So I am saying here is that I want to, in terms of how can we then empower this group even further? The language we use in the UK is talks about commissioning. I'm not saying that it must be the same as they do in the UK, but again, let's look at what has been achieved in the UK and say, how can we use that to influence, to support the development elsewhere? We've also heard what has happened in Ireland. So commissioning, it might be a technical word, but essentially meaning you have to take a professional approach in the way you actually plan your empowerment, your lobbying, your surrogate advocacy. You have a professional approach. So this means what is really So sorry about that. I don't know where that is coming from. We want to look at what we have to have a more formal way of clarifying the need in our particular area. And then we also have to have a more formal way of saying how map the needs around a particular region. So you do the need assessment, you map the need around a particular region and say, this is clear. I can see some of the things coming from what Asa'ah was saying in Cameroon. We also heard some of the things that Ashraf said in Uganda. So this is essentially need assessment. This is you map the needs, and then you say, okay, where are the gaps? Because all we're trying to achieve here is that tool that if you sit in front of a decision maker, you can say, if you're doing this to this community, what about this other community? That is the kind of lobby that we've been using in the UK, and you heard that the ladies doing the fairly similar thing in Ireland. in a sense that you're saying, if you are doing this with A, what about B? So, but then you have to have the evidence base by doing your needs and all that. And of course, once you've done that, the clarity, another issue is that, okay, if we come to you, why, if you say that you've argued the case of a need, how can you equally argue who is the best person to provide that? Now, you saw how the our organization in Ireland had to start building their capacity also by developing an accountable board. Now, but sometimes you hear this organization, you try to probe them before you say, okay, let's look at whether we can put a grant application somewhere. You try to probe the organizations, and then you find that clearly they are not accountable per se. And then you begin to wonder why, when they apply for grants, they don't get these grants. I'm not saying that that's the only correct. There are other reasons why grant applications fail, but it's very important to ensure that you have an accountability system in terms of you want to act as to be able to provide. Don't forget that you're an NGO, but then you are bidding to become to be a provider of a particular service, and that service must be provided accountably. And so you go through a procurement process, which is essentially, and in short, this slide just to say that these are the sort of things that we would like to tool the organizations that are actually coming on board in this arrangement. We're going to tool them so that they can actually be in a much better position to be able to provide and to be accountable partners to whatever resource that we are able to signpost them to, or a resource that might even come our way. So if they're not an accountable partner, it becomes a problem. Monitoring and evaluation is very key. We heard here some of the shoots that were green shoots emerging in the organization, saying to themselves what they've achieved over time. Those are some of the things. And then when you actually be able to do an assessment, you do your mapping, you have a clear capacity arrangement in place, you begin to convince somebody that you can actually work at world class. So next slide, please. Next slide, Mr. Folabi. Well, I don't think this is more or less saying that as an organization, you look at the fact that this is essentially talking about an organization acting as a community. You have a range of clients. Think about patients A, B, patients B, patients C, and D. They have varying needs. Now, as an organization, you have to be able to have the capacity to look at the possibility of addressing a whole range of needs. When I say an organization here, I'm not only talking about the NGO. I'm talking about the public health service in a particular area. In terms of a holistic approach, ensuring that you can address the challenge that people are faced with sickle cell from a range of perspectives. What, unfortunately, this particular PowerPoint is addressing the UK situation in the sense that a particular organization like the Sickle Cell Society in UK or in Ireland should be prepared to address this whole range of things if that the organization is going to act as a reliable hub for patient services. As a reliable hub and accountable hub, then you are now reached the stage where you can actually receive public service funding and provide service that is actually accountable. Next one, please. I'm just whizzing through this. So that was just to say that the whole concept of needs commissioning, which is needs assessment, arrangement in place where you can actually provide the need if you're actually resourced in an accountable way. But I want to bring us to the issue why patient organizations are vital. I'm talking to the convert. It seems to be converted because we know that sickle cell, as we heard today, has both medical and non-medical challenges to the individual, to the family, to the wider community. And so we've heard about the medical side. Let's keep that for our side for the moment. Now the challenge is the non-medical side. We heard about, so the reality we are saying here is that we need a pool of people who have the social justice interest to come together. Those pool of people with social justice interest coming together is essentially what is going to be addressed it will be needed in order to fight on behalf of that person who is actually facing the daily challenges of sickle cell. So because at the end of the day, like I said, you have both medical and non-medical challenges. So therefore, you want to, the ideal situation is to pool those people who can actually create an impact, get them together, and then that becomes what is known now as an organization. We've heard what the ladies did in Ireland. We heard what they did in Nigeria, but what is essentially the driving force? The driving force is essentially that it has to be equity. Now, equity in the sense that you want to argue more from, say, that you want fairness in the community. That's why I talk about, so I use the expression surrogate advocacy, in the sense that there is that one individual somewhere in some room somewhere who is timid, who is suffering from the challenges of sickle cell. There's not one family, yet there are other families who are effectively benefiting from what is available in the community. So we want to see fairness. Fairness in the sense that we try to give a push to that person or that individual, that family, to also be able to benefit from what the wider community is capable of providing for people. Now, so the patient organizations are there to deal with equity issues. When you bring them in that large number as a group, they can argue easily. The strength is there in the number so that they can argue for fairness. That's equity. I mentioned the case of cystic fibrosis and sickle cell. If you can do this to A, what about B? That's the argument we use a lot in the UK to say, if you do this to sickle cell, if you do this to cystic fibrosis organization, what about sickle cell disease organization? This is all equity issues. So we want to see fairness in the way the government, the state budget is actually being distributed. Same thing with support to families and their patients. With this, what we've seen so far, a lot of what is happening in Uganda, in Ireland, is support to patients and their families. But all this is because of the fact that you've created that institution called the patient organization. Let's do the next one, please. Okay. Now, how do you then actually influence? How can you actually influence policy? I state emphatically that this is learning from the UK, but and by extension Ireland. Yet we have all listened to, heard cases, clear case study as to how this approach has actually had significant influence in Ireland, and there's no reason why it cannot have significant influence in Africa. Of course, needing a subtle adaptation. So we are saying here that by having members, by nominating members in advisory bodies in the governance of the country, you have a position to influence. That's a direct input. By having consultation with patients and voluntary groups, you have ready-made data that you can actually support consultation. But like in the UK, if you want to find out information about people with sickle cell disease, you have to come to the Sickle Cell Society. And that's how that consultation with the Sickle Cell Society will serve as a lever for you to access patients and other voluntary organizations. We have the case of testimonies. We heard about powerful testimony from people today. All this is all, and there's a whole range of things in terms of a cohesion, so society values, information channels to provide information. So essentially, the role of patient organization is not only to address that person, but it's also there as a powerful tool to influence government through these various approaches. The approach of direct input, consultation, patient and carer experts, providing experts who essentially making sure that research is done as responsive as possible. Research has to reflect what the people actually and the community and the individual and their community actually need. And of course, and if you want to talk about trust in a community, if you want to talk about trust on sickle cell matters, it's only need you to make sure that you convince the Sickle Cell Society before you can actually get access to trust from members who are actually affected by sickle cell. So, and then I make the argument here, I say, if we can actually consider an organization which has as a clear objective to provide this various range of services that I've mentioned here, can we then say, okay, let's give ourselves a five-year forward view? And that's it. Remember, I made a statement about how we looked at the planning triangle in Ireland. The planning triangle, we were saying that, okay, here is the aims and objectives of our organization. Where do we want to be in 3-5 years' time? So I'm not assuming that at one moment think that you guys are not doing what we're doing, all these things. The various organizations that you mentioned today, you're doing them probably, but it's important that this is one area where we can actually make sure for those who are not doing them, who are not doing some of these aspects, can we then try and put the houses in order? Can we then try and make sure that we arrive at an appropriate capacity? So the short of it is, the response we are coming from here is that you heard the friends from Great Ormond Street saying that there is a need for capacity building to deliver education, to deliver opportunity for learning, in fact, global learning. But can we also make sure that we can actually have organizations that actually can be accountable, that organization that can be strategic organization? And this is all from a point of view of, I hate to use the expression, but I don't know any better expression to use, to say that this is essentially, we're talking about technocracy. We're building organizations that can actually stand the test of professionalism, so that we can then say that we have created sickle cell groups like we heard about the best practice that we had in Ireland, the best practice, the shoots that are emerging in Uganda, in Nigeria, in Cameroon. But we just want to make sure that we refine those further so that they too can actually compete. Why not with the big NGO that we know out there? There's no reason why they can't. We need to capture clearly what the needs are. We address the needs of those organizations, and then we then see how we can actually move forward and use equity. We then use equity. And once we build the capacity, use equity as the argument. I shouldn't forget by saying that the lever exists. The lever exists in the sense that in 2006, 2008, the World Health Organization, and of course, by extension, United Nations, actually came out with a resolution. The resolution was on sickle cell, resolution number 59.20, was on sickle cell and thalassemia, essentially saying that this resolution had two halves. One half was the governments of the world, the political, giving their will to say that they need to see these conditions actually improve things out, as of course, as compared to other, quite reasonably compared to other such conditions that the WHO has actually supported over the years. Up until 2008, the WHO had only been supporting the infectious diseases. But from 2008, we now, sickle cell came into work, 2006, by the way. Sickle cell came into the frame for the first time in the history of the WHO. A non-infectious infectious disease condition actually came into the frame. So what I'm saying here is that we have a lever. The lever is said that we have a resolution. But that resolution itself, in as frustrating as it is, we still have to ensure that we have built ourselves, our own capacity to that level, accountable level, where we can actually make effective exploitation, effective exploration of what those resolutions were meant for. People might say that since then, what has happened up to now? There are so many reasons why some of these things may not have, why the objective of those resolutions have not been achieved to today. There's so many reasons. One is because of the fact that effective lobbying is not happening in each of the countries. Of course, effective lobbying is not even happening at the level of the WHO. Effective in the sense that you go to WHO, you have to also ensure that there are partners that are ready to support you and work with WHO to deliver the objectives. I don't want to go into how a lecture and distract us with how the UN and the WHO work. Those are things that we can talk on the fringes if we want to know why. But my main mission here is, in response to all what we've heard, is that let us try and make sure that we also have built a accountable capacity within ourselves. And this is what I'm hoping that this seminar today is the basis on which we can support the organization that we've listened to today. And of course, others that might also come on board to support them towards accountable capacity building. Just one more slide, please. Mr. Folabi, the next slide, please. Okay, I think you can this is just to say that what has been achieved in the UK in terms of using these advocacy perspectives. Next slide, please. Again, just to say that just like most of the organizations have mentioned here, the work that we did, the work that I did in the UK, going back, was thanks to support from groups across the globe. We were able, through those groups, be able to influence the WHO and the UN to come up with those primary legislations. When I talk about resolution 59.20, that is primary legislation. We need now to take that to the next level by the implementation stage, which has got both political and technical aspects. I don't want to make this to be too complicated lecture. So this was just to acknowledge the evidence base that yes, we've heard from the service users. We're going to come up with a position statement which will capture a lot of the things that are going to, also in addition to the question and answer session that is going to follow this, we'll capture a number of things a number of things which are elements that we're going to build in the position statement, which we'll have to then go back to the WHO. We'll go back to WHO in Geneva, in Brazzaville, as well as right here across Europe as well, and say, where are we since 2006, 2008? But by so doing, you have to ensure that this organization that we are working, they should also have the accountable capacity before we actually go there. And I would like to thank, again, the Dr. Yinka Oduwaiye and his team for what we've actually, for the opportunity to actually revisit this. But we haven't finished our conference. That was just a quick one to mention that before we now come to where we have to now, I think we're going to constitute ourselves into a panel. Now the panel, but before that, it is very important that, like I said, it's a global thing. It's very important that we also have news from America. And I know that I've kept the chairman of the Sickle Cell, of the Sarah Ayoka Oduwaiye Foundation. We kept him waiting, the chairman across in New York, the New York chairman. We kept Mr. Albert Van Lare waiting. And I hope Mr. Van Lare, what you've listened so far is something that has kept you also thinking just like myself, and I hope everyone else. So, but we would like to hear from you now to actually address the meeting. And then after that, after you, we will be going straight into the question and answer panel. I apologize if we are running late, but again, you expect this to happen with especially when you're dealing with, I'm not trying to blame the user groups, because all this at the end of the day is for the interest of the user group. So I make no apology that we're running late. But again, it is very important that we hear from New York, and then we go in straight to the question and answer. There are lots of question and answers. Mr. Van Lare, you've got the microphone.
Thank you very much. Can you hear me?
I can hear you, yes.
Thank you. It's a good thing, actually, that you kept me waiting. I have been able to absorb a lot, and I have learned a lot just listening to the different speakers. So it's actually probably not a bad idea that I continue to do so. But since I have 15 minutes, I'm going to try and use 3 minutes. I still want to be able to learn as much as possible from the different speakers. I mean, it's so inspiring what I picked up from the speakers, the speaker from Ireland, the courage and the devotion of the people from Uganda, and this continuous spirit by the representative from Cameroon to just continue to fight and continue to stick to the determination not to allow this disease to suppress you. I think it's great. And I think it's a good idea that individuals can step up and actually expose their own personal experiences. A lot of us from Africa, we have this belief that you need to keep quiet or something came from some enemy. But I think forums like this will actually make it clear that to a large extent, we are masters of our own fate if we do the right thing. I don't want to leave out Ms. Ajibade, the young woman from Ilorin, Nigeria. I think she was fantastic. To actually move from the commitment to a job to say, look, I've got to devote some time to really spreading the word on this. I think it's all fantastic. And Doctor, you've been very fantastic too. I do think we need to have a second part to discuss that aspect of lobbying, organization accountability for the professionals. I think that has to be a separate agenda. Having said that, I'll just speak very briefly on what we do in America. The Sarah Ayoka Oduwaiye Foundation, essentially, in New York, what we do is try to be an engine to actually do the kind of stuff that we are doing now. We go into the communities, both the churches, as well as mosques, offices, and even unions, to talk to people about cancer. This is actually the first time that we are having an event that has to do with sickle cell. And I think it's great. And actually, and I think the end users have been fantastic. I mean, given the complexities of talking from around the globe and how organized this is, I must confess to you, it's probably the most organized session I have done in probably the last 5 years. Kudos to everybody. Fantastic. So what we do is try to bring awareness about breast cancer. It's essentially an entity or charity for breast cancer. But of late, we've been moving to other areas of illnesses. And Oduwaiye has been fantastic. He's been to New York, and you can see on your screen, that's one of the presentation he made to a group of professionals in an accounting office in New York. And I think this was 2019. Can we get slide 2, please? Okay, actually, that's me at the mosque in Brooklyn, New York, where Oduwaiye came and he also spoke. I believe that was 2019 too. Let's see the next one. That's Oduwaiye actually speaking at the mosque in Brooklyn. One of our board members in New York, actually, it's a member of the board. Myself, Oduwaiye, and himself, Alhaji Lanlokun, we are all friends from our youthful days from secondary school back in the 70s. Next slide, please. Yes, this is him speaking at another conference at another union. Actually, this was the first time he came and made a presentation in America, and we had people from Doctors Without Borders, all kinds of medical and social services organization. It was a fantastic experience. Next slide. Oh God, this was last month. And that was me actually with Professor Rahim. He's a new friend of SAOF and the proprietor of Nana Aisha College of Education. I am looking to establishing relationship with them because we want to reach out to the schools and we want to have forums like this, have student participation and get the words out. And that was me last month in Nigeria at his farm in Ilorin, Kwara State. Go ahead, next. And me with him as well on my way out of Ilorin. I think that's the end of the slide, correct? Mr. Falabi? Yeah, that's it. Now, I just want to say a few words. This organization was founded by Dr. Oduwaiye, whose mother died of breast cancer when he was in medical school. And this is what actually made him to make a determination that no matter what happens, he's going to devote a substantial part of his life to fighting breast cancer, giving education, letting people know what the dangers are, the awareness, early detection, and everything else that needs to be done. And he's done a fantastic job. He's been doing this 14 years, and most of the expenses come directly from his pocket. Thank you again, Dr. Oduwaiye. Thank you, everyone.
Now, this is fantastic. Very passionately delivered, and in fact, very interesting history giving us to the origin of this foundation. I would like now for us to, because again, I apologize if we kept people waiting. I think this is going well over almost an hour above our time, that the time that we actually allocated for this conference. But again, like I said, I hope you are also just as passionate as the service user groups that are actually that have been speaking. So we're going to start taking some questions, and there are lots of them that have been coming through on the I want to again reassure people that there are people behind the scenes capturing and outline what will eventually emerge as position statement, which we will circulate after this to all the key stakeholders, so that we can then develop an advocacy pack, which will then serve hopefully to strengthen the organization, strengthen the capacity further for all the organizations that have taken part today. But also my colleagues, my friends at the Great Ormond Street Hospital, who have actually mentioned, we're going to follow that through to make sure that we link all the organizations here with them to see how they can actually take forward the initiative that Ade and Dr. Lola were talking about. So I'm not sure who has been capturing the questions, but if I scroll on the chart, what I would do is, as we raise one question, and then this priority be given to the members of the panel. My understanding was that one of our senior colleagues in the NHS was actually in attendance, who is actually a consultant, hematology with special interest in hemoglobinopathy. Is Chuli still here, or is Chuli gone? Is Dr. Oduwaiye, is Dr. Chuli Yegen, is she still on or she's gone?
Dr. Asa'ah, I've made a note of the question, so we're going to do it on our end, if that's okay. So we'll put
Excellent, wonderful. There you go. I just wanted to make sure, is Chuli still on?
Well, we are not sure. She hasn't responded. I assume maybe she's not on.
Well, anyway, we will take the questions, and the ones that we here cannot, we feel that we need some time to address on a one-to-one basis. We'll do that. But thank you so much for actually helping us today. Can you just say who you are, please?
Yes, that's what I wanted to do, actually. I wanted to introduce her. She's one of my colleagues and a partner in the practice here. Her name is Dr. Taj. She's been here on our forum last year. She's actually summarized some of the questions. So she will read the question out, and any of the panelists can actually answer it, and anyone she or myself can answer, or Dr. Bale will answer. And some might be for you too, or even for our chairman.
And even the patient groups.
The patient group has been a very good friend of the SAOF in the UK, and we really use this opportunity to acknowledge you. Thank you.
Thank you everybody for your contributions. It's been a really interesting day. I've heard some really powerful stories, and I am really blown away by the expertise and the wisdom and the the faith that people have who've attended today. So thank you, and I'm very proud to have been part of it. So we'll try and do the questions a bit more quickly than the 30 minutes that's allocated, because I'm conscious that people will have other things that they want to be doing. But there were lots of questions about medication. So I'll read the first one out, and if anybody wants to answer, either just unmute yourself and speak, or raise your hand if you want to. And so the first question was, what are the side effects to medication that's used to treat and to prevent sickle cell crises?
So, you want me to make a comment?
Yeah.
We've got some we got the hydroxyurea, which it's got a few side effects, and the most serious side effect is that in some patients it could cause bone marrow suppression, and which means the white cell count, which is there to fight infections, could be very low, and in such patients, and then the hemoglobin may be low, the platelet count may be low. In such patients, the advice is that they've had a failure of treatment, and then that has to be stopped. There are also other minor effects like hair loss, abdominal pain, nausea. Those are very, very minor side effects. But the main side effects to worry about is the the bone marrow suppression, and that is why all patients who are put on this medicine should be registered with either the GP or the specialist sickle cell team, so that they get blood tests regularly. They're told about side effects, and that makes it more efficient. And those centers normally do audits regularly.
So, and that's brilliant. And that brings me on to another question that we had, which was, what are the long-term side effects of being on hydroxycarbamide? Does it actually work for all patients?
Doesn't work.
Can I just interrupt? We need those who are not in the room to be able to hear, please. So a little bit. We just want to make sure that the questions are repeated. Whoever is answering to repeat the questions so that the others outside can actually follow.
No problem. So did everybody hear the answer to that question? Was that clear?
No.
It wasn't clear,
and then you can repeat it. Read the question out.
And so we were talking about side effects to medication, and the summary was that there are minor side effects to hydroxycarbamide, and there are major side effects. So one of the major side effects would be bone marrow suppression, which is when the cells that are produced to make your blood and to provide your immunity are depleted. And that brought me on to the next question. So a couple of people asked, what are the longer term side effects of being on hydroxycarbamide, and does it actually work? So that was the next question.
It works because there's been some scientific papers that have been published, and it shows that these patients have got more than 50% reduction in complications, painful crisis, anemia, fewer blood transfusions. It works very well, and we've had lots of patients say that since they've been on hydroxycarbamide or hydroxyurea, they've had fewer serious acute crises. So which means some have not been to hospital for 4 years. They get minor crises which they manage at home. And the good thing is it reduces the number of admissions. So it's been quite very effective. And it just kind of, it was in the long presentation, which I couldn't present all of that.
Somebody else also asked, are antibiotics the only thing that can be used for sickle cell crisis?
No, kind of antibiotics are used if there is a high suspicion that there is an infection. If we suspect the patient has got a chest infection, like from chest infection, stuff like that, or the patient has got a temperature of 38 degrees, then antibiotics come in. Lots of the patients will have painful crises that could just be from hypoxia, dehydration, or dehydration. Not all patients will automatically have antibiotics.
And somebody also asked, what are the potential long-term implications for repeated courses of antibiotics and pain control for sickle cell crises?
Well, for the repeated courses of pain control, there is the worry that some patients may be dependent on opioids. That's why when I present, I said normally the patients are being kind of being referred to the kind of pain clinics, because then they could be able to titrate their medicines and kind of learn how to wean the medicines of the patients to prevent patients being dependent on high doses of opiates. So it's kind of, that is why everybody should be registered with the GP, registered with the specialist sickle cell teams, and that makes efficiency.
So basically, if you're
I think I might have missed one of your questions.
No, that's good. That's excellent. And yeah, ultimately, you want a specialist team around you. You want people who know what they're doing, so that they can talk holistically about the issues around treatment, managing an illness that can flare and is also chronic disease.
Just something it's important to remember that sickle cell patients will have chronic pain, and chronic pain patients could need some psychological support and input from psychologists, neuropsychologists, and we kind of teach them coping mechanisms on how to manage their chronic pain. And of course, they have frustration because they may not be able to do other things they want to do, work and stuff, exercise, but with the psychologists, the Sickle Cell Society, and all the other advocacy support, they get good support and their management gets better.
Fantastic. So somebody else asked, do immune boosting supplements have a role in sickle cell disease?
I would say I know much about that, but Dr. Kabula may do some.
Some of the other.
Yeah. But I wouldn't say I know much about it. I'll ask the other members of the panel.
Do any of the other healthcare professionals want to comment? Does anybody have something that they suggest on that?
Can you read the question again, please?
Do immune boosting supplements play a role in managing sickle cell disease?
This is where, have we got Dr. Kamara? Dr. Kamara is still on? Is not on. Dr. Mbene, are you still on? Okay, can I just say that what will happen is—
I'm still here. I don't know.
The camera is still here. Okay.
Yeah.
I don't know if you followed the question about immune boosting supplements, if they are effective.
Can you repeat the question, please?
Do immune boosting supplements play a role in managing sickle cell disease?
Immune boosting supplements. Well, I mean, if you have something that causes immune suppression, then obviously you need something to boost you up. Other than that, you then become susceptible to what you call them now, the superimposed infections. And that is the role of the boosting. Because as it is, it's like someone who's got a cancer and is, they're immune suppressed anyway. And then you go and add chemotherapy or radiotherapy on that. So obviously that person needs to be super protective of what they're doing. Other than that, they get exposed and they get immune, they get the infection, and the infection obviously would probably be worse than somebody who isn't in that particular status. So therefore, you need those boosters to actually increase the uptake and to get yourself better. It's as simple as that. So it's like robbing Peter to pay Paul, and that's the only analogy I can give you.
And what immune boosters would you be alluding to there? And is there anything that, because I think the question was probably based around over-the-counter stuff. So do you have any further comments on that?
I would probably refrain from taking on board OTT, as they say, over-the-counter OTC. I think it'd be best to lean more towards the specialists' advice on this. I mean, hematologists, you know, the lab technicians, the specialized nurses and all that. They're more familiar. And I think they're more equipped to actually give advice on that than you going over the counter. Because the tendency is for you to be told herbal remedies and all the rest of it. And we know they're fraught with all sorts of complications. So I'd say lean more towards the specialists who are trained for that. And that way, if there's any complications, you know, at least you've got something to go back on. But other than that, you probably are now hiding to nothing.
I noticed that Dr. Lola only has her hands up, but I just want to make a point that so excellently grateful for all my the clinical colleagues who are actually putting themselves on the spot here. And I want to reassure all the folks that the questions that are coming through, we will again as a team, all of us, all of myself, clinical scientists and the clinicians who are actually taking part here, we will review all and then make sure that we produce a compendium of the questions and the answers. And by so doing, it might mean that we might also, as Dr. Kamara said, perhaps seek some second opinion of the UK forum. This is just to ensure that to protect my colleagues who are actually listening to it, in as much as as like I said, they're physicians. I'm not. I'm a clinical scientist, but we will have to make sure that what we're doing here, the UK forum is actually there as a backup, so that we will also, the compendium will come with questions. So far, I'm totally behind all the answers that I'm getting anywhere, not to put doubt in anybody's mind whatsoever. I just want to reassure people that what we are doing here, the UK forum exists as a backup organization for this kind of work when it comes. UK forum for blood disorders I'm referring to. And at this point, maybe I want to take Dr. Lola Oni. You had your hand up. Dr. Lola Oli, you had your hand up from Malta.
Thanks, Asa'ah. I was just going to comment on that question. Certainly, in my experience in the specialist field, we always recommend that our patients take a general multivitamin supplement, primarily because a lot of people, particularly in Africa and the Caribbean, are folate deficient. Not so much so in the UK, because there's a lot of foods, particularly cereals, that have folic acid added. But certainly we do say it doesn't do much harm to take just a general multivitamin on a daily basis. Of course, we're all well aware of the importance of vitamin D. And quite a number of our patients are vitamin D deficient. And in those cases, we actually prescribe vitamin D, and usually at a higher dose than what you will get in the multivitamin tablets, etc. So the usual recommendation is a general multivitamin, but if we feel somebody is deficient in certain areas, then they'll be prescribed. For example, if they're deficient in iron or vitamin D and so forth. And of course, we also look at, you know, whether they are on, for example, on blood transfusions, whereby they may be iron overloaded. And in which case we say to them not to take vitamins that contain iron because you don't want to increase, you know, their iron loading. So the best thing, you know, as the previous speaker suggested, is to speak to your specialist nurse or specialist doctor to find out the specific need for you, because they will know whether a general multivitamin is sufficient or whether you need something a bit more, or whether there are aspects of multivitamins that you need to leave out.
Thank you.
That's really helpful. Thank you very much.
If I can add to that, sorry, I just wanted to just buttress that. See, my colleague just highlighted vitamin D. I want people to understand that too much of vitamin D can cause all sorts of problems, including stone formation and blah, blah, blah. So it's important to ensure that the vitamin D that you're taking, as I said, I didn't want to mention that, but it just goes to show vitamin D is absolutely vital. But because you've got sunshine and, you know, we've got this melanin and all of that causing problems in production, there's an issue here. Some people need like 20,000 units a week. Now, some people need 1,000. And how would you know that? You have to measure it. And because measuring it is a very, very pricey thing to undertake. That is why the GPs, the general practitioners, are not doing it anymore. So what happens here is that if you take the standard 1,000 microunits, yeah, that should be okay for you. But then if you have the need for 20,000, and you're taking 1,000, you're actually underdosing yourself. So the only way of getting to know what is specifically tailored for you is definitely to get that measured. And that would be done by the specialist, by the, the GPs and things like that. So that's just a word of caution. But it's important to remember that over-the-counter stuff is very difficult to actually measure what is bespoke for that patient. Thank you for that.
Just a little word. Vitamin D test is kind of part of the annual review for patients with sickle cell.
Yes, we do that, yeah.
So we have one other medication-related question, which was about, a couple of people asked about a medication called crisanulism, which I assume is immunotherapy. And if anybody wants to comment on that and its role in sickle cell treatment, that would be really helpful.
It is available, but you're looking at the question of availability, the question of affordability, and of course, whether it's tailor-made for that particular patient or not. And of course, you need to think about the side effects of it and how you combat that. So it's not just a straightforward thing. It's something, as I say, again, dependent on the hematologist, who is obviously specialized in that. But that is obviously something that is available. But then in Africa, do you have that? Can you afford that? That kind of thing. So you're looking at availability, you're looking at affordability, and all the other issues surrounding that. That's all I can say to that. But it's something that is available maybe to the Western world, the first world as they want it to be called. But it's important to think about Africa, which is what we're looking at in terms of our people there. Is that something we would actually be able to provide? Or is it something just for the few and not for the many? This is a question I think that is important to consider.
Yeah. There's a couple of other questions about PGD, so pre-implantation genetic diagnosis and its role in preventing sickle cell anemia, and also a question about gene therapy and stem cell transplants. So I don't know if anyone wants to talk about those.
Mr. Kamara, would you want to contribute to that?
From what I gather, sorry if I should say, from what I gather, these are all, as I said, the thing with the UK and maybe other developed world countries, as it were, is that they don't just take things and then say, well, that's it, this is what we're going to do. It's something you've got preclinical, clinical, and then of course you get the tick box to actually go for it. And then thereafter, you would then say, well, let's monitor what's happening. But of course, these are all in the pipeline. These are all being practiced in terms of experimental. It hasn't come to the point where it becomes a mass production. That's the thing with it. It's there. They're doing it. In fact, the research that I know is taking place in Great Ormond Street Hospital is that they're in the final stages, maybe to try and experiment it, where they would have that, in vivo, if you like, implantation and things like that. But because it's not been formalized, then we as clinicians, we like grade A evidence. That's what will guide you, because you can quote and fall back on it. So until it gets to that stage, it is just at that stage, really. And I think that's what it is. But it's good news to hear that we're at the point where we're thinking of curative rather than preventative, in terms of approach in the case of sickle cell anemia. So bravo to that. And I can't wait for that to come to fruition.
Let me just, Dr. Kamara, let me just add a little bit to what you just said. Maybe for the benefit of the lay audience, PIGD, pre-implantation genetic diagnosis, if that's what was the question was, it is, what happens is, it's a process which enables you to actually screen the pregnancy at a very early stage before implantation. And therefore, by so doing, you can then eliminate the pregnancy if you find that at that stage the egg actually has the chance of becoming producing a sickle baby. There are all sorts of issues involved here. There are ethical ramifications, but it gives the couple the opportunity to be able to decide whether they're going to implant the sickle, the actual egg, which is going to be produce a sickle baby or not. So it's an issue. It's kind of a screening, another screening method. Then obviously the next step is the water of those sort of early stage genetic manipulations is what Dr. Kamara was talking about. And that is already, in terms of PIGD, there are quite a few places that are being practiced already in the UK. Those who would like to know, if they want, we can actually address those laterally and actually signpost in those areas. And by then they would then need to link up with the necessary place directly. We can provide that information offline. Then, as Dr. Kamara said, there's interesting, aside from the diagnosis, there is also therapeutic advances in terms of actually treating the illness genetically. There are a number of things that are happening in that front. I just want to important for the lay audience to understand what the PIGD actually meant. It essentially means screening the embryo before allowing the embryo to implant, so that you're actually selecting what you want the pregnancy outcome to be.
And that all happens before the pregnancy, so that happens outside. So it's not like it's not akin to abortion. It's the eggs and the sperm are mixed outside, and then they look at the genetics of the embryos, and then there's a choice.
Yeah. Thank you.
No problem. So there were a couple of questions from sickle cell warriors in their 50s, and they were saying, what is the life expectancy for somebody with sickle cell? Somebody did write an answer which was very nice and basically said there is no definitive life expectancy. It depends on the type of illness you have, that sort of thing. But I thought it might be worth, if people are worried about what it is to be living in older life with sickle cell, you know, what reassurance they could have from that.
Well, if I can comment there, we don't commonly give people a definitive thing that you're going to die today or you're going to die tomorrow. I'm sure you realize our experience here in Egypt. When we were junior medics in Nigeria, we had a case of a consultant who gave a verdict that the patient had some few times to go, and the consultant even died before the patient. I always advise people to live here. God heals. So nobody has a say that you have a magic wand that, well, you don't know what will happen, but we keep trying, except if the patients decline treatment. I'm not an advocate of euthanasia or anything like that. But you find that even cancer itself, people have lived up to old age. You see some of our patients here in Philippines, isn't it? Yeah. So nobody can draw a line. Only God gives life and only God takes life. So it's wrong for anybody saying you are going to die tomorrow, you are going to die. But the most important thing as a patient, living with chronic illness, believe in yourself, believe in your doctor. If you're not happy, seek for other help. But to say somebody is going to die today or tomorrow, I don't think it's right.
Keep your appointments, take your medicines, look after yourself.
If I can add to that, you see, growing in Africa, the understanding was anybody who's got sickle cell anemia would not live beyond 20 or beyond their 20s. Yeah. That was the impression, and people believed in that, and it was such a myth. And that's why my talk was centered around the myths. It was like a myth-busting talk. Because of the advances so far that we've all heard about today, I think above average would be somebody who lived. One of the patients that I dealt with was 80. They actually reproduced about 5 kids, and they were fine as they went ahead, But that's the exception. But I think on average, you'd say 50 and above because of what has happened. The antibiotics are there, they're powerful, the knowledge of rehydration, the knowledge of their own plan, the individual plan, tailor-made, bespoke, and people are a bit more aware, people are a bit more sensitive, people are a bit more educated about what sickle cell is, and they know it is not contagious. It is something they got from their parents, and therefore they can deal with it. And they know that if they actually make sure the remission rate, is quite significant in comparison to the relapse rate, they know their lifespan will be longer. And they live fulfilled lives, productive lives in that. So thanks to the advances and thanks to the fact that there is that education and the awareness, a lot of people live longer than expected and way beyond the expectations. And that's, I think, is something laudable and something applaudable, and we need to continue doing that.
Yeah.
So just before, just to emphasize the message from the clinicians, especially what Dr. Obale said earlier, and I think Dr. Oduwaiye said the same thing. Trust your doctor, keep your appointments, follow all those regular checkups, and then you'll find that the life expectancy is improving far more nowadays because the knowledge has increased, and also there are therapeutic advances which ensure, we've just been talking about hydroxyurea. Those are things that actually keep you away from hospital. If you follow your doctor's advice and then make sure that all the triggers that you would have been told, avoid those triggers to make you to push you into serious health situations. So yes, people in UK are living more and more to normalize life expectancy. You would look around to speak to your friends, those in the UK, I must say, you find more and more people getting to 70s in the UK, because there's a lot of advances. I suppose probably the same with the US and some maybe other European countries, because the knowledge has improved, the treatment is there. But again, it's coming all because of some of the things that you people are doing, the patient groups, the advocacy. It means that equity is coming in. The equity coming in means investment is coming into the sickle cell side, but we need to then try and see how this can be carried to Africa and other places. So those are areas where some of conferences like this will enable us the tool to actually empower people to try and push those sort of things. I just wanted to throw a bit of it to say that the salient message, follow what your doctors are actually saying. Very important, go to your appointments and take your medications.
So on the flip side of that, there was a question about young people and children, and the question was, is it possible to stop crises before they get worse in children who are growing up?
Yes. I think parents especially, they get lots of education about sickle cell, and each mother or father knows their child. They could know that if a child stops being active or wanting just to sit quiet, there might be something wrong. Sometimes hydrating them, keeping them warm, giving them analgesia. If they have something that looks like a chest infection, some parents may be proactive about starting them on treatment, and just that they could stop mild infection, mild crisis becoming a major crisis.
And perhaps let me just add also from the UK Department of Health perspectives that, or the UK Forum for Blood Disorders, when the doctors have been talking about hydroxyurea, they are the physicians. Hydroxyurea has been proven to reduce hospitalization rate. It has been proven. I know Dr. Kamara talked about grade A. It's actually grade A, in the sense that the argument is relating to this specific question. The argument is that if a child has more than 2 crises a year, then they should be put on hydroxyurea. And this is actually clearly, I'm citing here guidelines that are published in the United Kingdom. Now, here is some of the challenges we keep talking about UK, but the question my friends in Africa will be saying, what about us? This is some of the things, the best practice examples that we are hoping that the kit will enable us to start supporting the advocacy outside the UK, so that some of this kind of practices should also be emulated in certain places in terms of access. But yes, you can reduce the number of hospitalization by putting a child permanently, a client permanently on a hydroxyurea. This is actually great evidence, and that will therefore hopefully reduce the need. But yes, in terms of the triggers, I'll follow what Dr. Obale and the physicians are actually saying. I will actually submit to them. In terms of the triggers, those triggers, but then just know that when they are recommending you to be on hydroxyurea, that's the reason, because you actually stop you from going to hospital if you have more than 2 crises a year.
Thank you. And then one final question. So there was a question at one of the first questions was, why are the rates of sickle cell anemia more common in Africa than other parts of the world? And following on from that, then another question was, why is it so high in places like Nigeria, Ghana, and Uganda?
That's an interesting question, isn't it? There's so many permutations in that one. You can think of, really. I mean, why is it prevalent? And in my delivery there, you saw that the belt of malaria is more or less repeated by the belt of sickle cell, and there may be something there, maybe food for thought, maybe some research projects coming up as to why it is. When I delivered the talk on monkeypox, I was asked the same question: where is it endemic? And then the answer was, it's endemic in the DRC, not wanting to point fingers or whatever. We know that. But then somebody asked the question, when Ebola that actually happened in West Africa, in 2014, had a similar, origin, DRC. So what is there in DRC that we don't have in the west coast of Africa? I couldn't answer that. Is it something in the terrain? Is it something to do with the wildlife? Or whatever, I don't know. So that's something I think we need to be taking back to see where we can get answers from. But it's quite obvious that where there's poverty, where there's lack of affordability in terms of healthcare, obviously something avoidable will become unavoidable. It's a simple logic. Logic dictates that if you can afford to be buying all this medication, to be visiting the doctors, to be taking on board the transfusions and all the rest of it, following whatever it is that you've been told, having your own annual review, being conformative in terms of what you've been asked to do, eat well, rest well, avoid the triggers, and know your own body. And I'm sure that would increase, but it's quite obvious that there's no equity. Just like my learned colleague is saying, there's no equity. And this is the essence of these webinars. We need equanimity, we need equity, and we need equality. How do we achieve that is what this is about. So let's be speaking to our governments, let's be speaking to our people, getting them educated, getting them sensitized as to how to live, to lift this up to their own politicians before they put them in office. That is the thing we're talking about.
Thank you very much. Thank you, Dr. Pat. Thank you. Thank you.
So I will
Can I the Ugandan experience?
Hello?
Can I share about the Ugandan experience?
Yes, of course.
Okay, because that's why the prevalence is high in these countries. In Uganda, the study that was done in 2016, it looked at the relationship between malaria and sickle cell. And it was, the results revealed that in areas where malaria is high, sickle cell was high. So in Uganda, the northern region has the highest malaria prevalence and sickle cell prevalence. The eastern, it's the same, and the central region comes third. So there's the results revealed that there's a relationship between malaria and sickle cell. Thank you.
Thank you very much.
Oh. Thank you.
It's interesting that, sorry, it's interesting you say that. I'm really glad you said that. Just imagine, he's saying the relationship between malaria and sickle cell. Now, if we, as far as I know, geography, which I did many months ago, I think the wettest capital in West Africa is Freetown, which is where I come from. Yeah. So because you have the rainfalls, and especially as we speak now, the puddles, the rain, and then of course you've got the mosquitoes. You have, the larvae and all that, the rest of it. So it's like if you prevent that happening, you're more than likely to reduce that. And that is why, if you look at what is happening, the WHO did, I don't know, maybe my colleague would actually confirm this. The exception is that every vaccine that has been found for any illness, it has to be 50% or above efficacious. But in the case of malaria, it has actually been 25%. But as we speak, they made an exception, and now they're actually trialing it in places like Uganda and I think Zimbabwe or something like that. It just goes to show you the desperation. So if there's a link between malaria and sickle cell, I think this is something that we need to be looking into in terms of maybe further research, maybe. But if we prevent malaria, perhaps there is the clue there to prevent maybe more of the sickle cell. I don't know what, but that's just food for thought.
Brilliant.
I'll just talk about some of the questions.
And so if there are no other comments, thank you very much for everybody who's contributed to that question and answer session. I will hand over to Dr. Oduwaiye.
You hand over to the chairman.
Oh, sorry, apologies. I'll hand over to the chair.
Yes, thank you also. Can we just reassure people that even if you have subsequent questions, just send, because when the recording will actually be shared with all the stakeholders, and even despite that, if you still have further questions, send them through, because we're going to have to pull all the questions together and then come back with a compendium of question and answers, which will circulate again to all the stakeholders. So it doesn't stop. I noticed that there's a physician I think in America already asking for some of the slides, of Dr. Obale. They're already asking for that online. And these are things that we'll pull all together and then come back to people. So yes, even after this, if you have any questions, don't hesitate to come back to Dr. Oduwaiye and team. And I would just want to say that we, like I said earlier, we just don't want this to be another of those conferences where they speak and then nothing else happens. Otherwise, it will be very frustrating next time we ask you to come and you say you had enough of it. We're going to produce some sort of an outcome pack which will act as a support for your advocacy activities. And we're also going to link everyone with the team from Great Ormond Street, as well as others who we know are actually online following this conference. Like I've been seeing them on the list. We'll link them up and then make sure that there is some, this is a conference like no other. And we want to thank Dr. Yinka Oduwaiye and all the team at the Sarah Ayoka Oduwaiye Foundation. And we hope that this is something that will prove to be something that we might want to revisit this and make it an annual event. Why not? At this point, I want to hand back over to, did we say that Dr. Odebami, is he back?
Well, I'm not sure.
No, anyway, I think I want to thank everyone. And at this point, and I'm very grateful. And like I said, it's the medical world's opportunity for us to show that we can do something to the next level at world-class level. And I think already the shoots showing that we have pulled that together today. And I thank everybody for your enthusiasm. It's overrun a bit. Well, another hour, but we would like to pass over to Yinka to actually to give the final remarks and close the event.
Thank you all. I hope you are hearing me. I hope you are all hearing me. Hello?
I can hear you. I can hear you.
Yes. I hope everybody is hearing me.
Yes.
On behalf of our chairman, understand he's held up somewhere. It's unfortunate he couldn't speak earlier, but he has to go for another meeting. That's Dr. Banju Ibabi. And also our chairman in America, Mr. Albert Van Leer, and all the trustees in America, in Nigeria, and here in the UK. And all of you have actually spent time. Dr. Valley left Manchester very early to be here today. One can actually not quantify where this will go, but we can see the response. We really, the journey of 1,000 miles starts with a step of faith. The whole idea of this, whether sickle cell, cancer, diabetes, summary of all what we are saying today is all related. PHD, poverty, hunger, and disease. That's what is killing our people in Africa. If one thing we take home from here today is to empower the helpless back home in Africa, to give them a leeway, to have a chance. Here in the UK, where I'm staying, people come, pay nothing. They get the best of service. That's not what you do here. No cover. NHS is from cradle to death. Hopefully, one day we'll get there in Africa. We really thank Dr. Asa'ah Nkohkwo and his team. And he has said, hopefully we can move this forward so that the end user back home in your village, in my village, in Tanzania, in Uganda, can actually have a say and have a better life, good quality of life. It's not been an easy journey getting this far. And we must commend all the food workers, from the cleaner to the suppliers, to all those who provided food for us here today. And the musician who had to come all the way from West Midland. We thank you all. This is just the beginning. Hopefully next year we'll improve on this. We thank Dr. Asa'ah Nkohkwo, the Sickle Cell UK, the Irish group, Tanzania group, Cameroonian group, just name it. And our honorable friend, Dr. Kamara, and Dr. Bale from Tayside Hospital, Manchester. We really appreciate you all. SAOF, like any other organization, is doing its bit, but we need help. A lot has come up today. People dying just because there's nothing for them back home in Africa. But we can make a difference starting from here. We appreciate you all and we thank you all. We use this opportunity to thank all our patients here too in Philippines, Mrs. Ansa and family, and a lot of others who have actually left. We really appreciate you all. We thank you and God bless you all. Thank you.
Yeah,
God bless you. Thank you. Bye. Thank you. Thank you.
Thank you all. Bye.
Thank you, everyone. Goodbye.
Thanks all. Bye.
Thank God for your sister for coming.